Please start, sir. We are live.
Okay. So, good afternoon, everyone. Good afternoon from India. It may be good morning for some of the people who have joined from outside India, and it may be good evening for some of the people who have joined from outside India. So, we welcome you, everyone, from the team of NfECHO, that is Neonatal Focus Echo Academy and FOCUSin Academy, that we have been running the programs for the neonatal echo training and the neonatal POCUS, point of care ultrasounds. So this program, you have been there, if you have been seeing this in the group. So today, this is around 4.5 to 5 hours of concise, very short course, I would say, for neonatal POCUS, point of care ultrasound, that includes head ultrasound, echo, and lung ultrasounds. So these are the three major components. But as you may be seeing on your screen, that for this already now 1800 delegates they have registered already from more than 29 countries. But recently there was an issue with the WhatsApp, so I couldn't add everyone in the group because my WhatsApp has been blocked 5 times in last 3 days. So that's why I'm trying to spread the link to as many as possible to get the benefit of this. And this is a kind of maybe a global CME on neonatal hemodynamics. The whole program you could see in your screen. We will start with the Dr. Kiran More from he is there. Hello, Dr. Kiran.
Hi, good afternoon, everyone,
Good
or
afternoon.
good morning, good evening, wherever you are.
Dr. Ankit is there. Good afternoon, Dr. Ankit.
Good afternoon, sir. Good afternoon, everyone.
It will be good. I would request the sport to, if you can start with the recording also for this, please.
Yes.
Good afternoon, Ankit. It will be good if you start your camera.
Yeah, good afternoon, sir. Good afternoon, everyone.
Good afternoon. Yeah, so we will start with the basic principles. Then we would go to this. Dr. Kamal will show you live, like how to have a optimized image. That is very important before going for any of the views in neonatology. Dr. Ankit will show you the basic normal views of the head ultrasound. Then we would show you the live demo on the babies in NICU, that where to keep the probe, how to see the basic views. So then there will be half an hour break. Then after the break at 3 p.m. Indian, all these timings are Indian Standard Time. So please adjust your timing as per your local time that matches with the Indian time. Then we will start with the basic normal views of the heart in the functional echoes, and we will do the live demo of that. Myself and Dr. Kiran will do the live demo for the same. Then we will go for lung ultrasound. That is very important again, and we'll go for live demo. So we have tried to cover this. Soon after some days, we will be coming with specific topic CMEs of the neonatal hemodynamics like PDA, PPHN, and shock. So we will keep on informing you, and hopefully we will take care of that WhatsApp glitches what we have been getting. This is our program. So before starting the program, I would like to thank CIPLA for giving us this platform for the online CME. So I would like to thank and mention CIPLA for the same. And then I would like to introduce some and tell you regarding few of the facts regarding our NfECHO Academy and FOCUSin Academy. Then we will start with our program. So NfECHO Academy and this FOCUSin Academy. NfECHO Academy is being headed by myself. It's based in Surat. FOCUSin Academy is being based at Mumbai, headed by Dr. Kiran More. So basically, these are the same platform. So we have been doing a neonatal echo and point of care ultrasound courses, and it has been around almost 1.5 years. So third batch is going on. We will be starting the fourth batch from January 2024. The registrations are going to be closed soon. So if you are interested, please WhatsApp on this number, or you can email on NfECHO2505 at gmail.com. So I would like to just show you that what all things we have been doing till now, and what are the few of the details regarding these courses what we are doing. For Indian people, we have PCPNDT Act. So because of that, we have to have a 6-month certified courses. The academy is being registered with the government of India. So hence it has been recognized by government of India. So these are the 6-month certified courses. There are two formats of that. One is the complete online course for 6 months. We do twice a week or thrice a week sessions in the night. And then we have live demo of the same sessions. Like if we are showing the views of the heart, so we will have the live demo. Like today, you will see that sample for that live demo on the babies. So that is one complete online course. For hybrid courses, along with the 6 months online sessions, you will have the provision of 2 weeks physical hands-on. But for that, you have to come for 1 week at Surat and 1 week at Mumbai. You stay in the NICU for 6 hours in a day and keep on doing n number of echoes. How much you can do, you will have the practice on the live babies in the NICU. And then we have been conducting in between the online crash courses also. And we do have the pure hands-on courses, which varies from 1 week to 4 weeks, depending upon how much experience you have and what is your main aim of coming for physical hands-on courses, for varying from 1 week to 4 weeks. What all you get during these courses? In these courses on neonatal echoes, neonatal echoes, head ultrasound, lung ultrasound, abdominal ultrasounds, they are all in line, how to put in the ultrasound guided lines, how to look for the tip, all is being covered. Sessions are being taken by neonatal and pediatric cardiologist and radiologist. More than 50 sessions we do in 6 months course, and you are able to have all access to these recording sessions in your batch for lifetime. We do live demos of all the views of NICU for all aspects, for head ultrasound, lung ultrasound, cardiac ultrasounds. Regular candidate assessments we do. You along in that course, you will get as a package, you will get 5 books written by our team, and more than 500 published papers, full papers. You will receive the soft copy for the same. And we are coming up with an app of NfECHO and FOCUSin. So you will be getting the free subscription for the app. So these are the benefits you will get. And I would just like to share a few of the things, like from first batch, this is some of the physical people who have come. And then in the end, we had the graduation day for the batch. Our team has till now conducted 72 echo and POCUS workshops worldwide. And more than 26 international candidates, they have in the last 1 year, they have come to our unit. These are the neonatologists, doctors from Bangladesh for physical hands-on training in our unit. These are the pictures for that. So we had candidates from Indonesia, Dubai, Bangladesh, Indonesia again, USA, Qatar, everywhere. And many from the first batch, 2 of our trainees have now been regular faculties in all of these workshops we have been conducting in India and outside India. So these are the courses we have been conducting, and that was our detail. So now we go ahead with the program. I would like the sport team to please share the faculty CVs that will be doing the sessions today. So we have, like, it will be a great honor for us and great honor for me, my colleague who have been trained. We have both have been trained almost at the similar places, has a vast experience, and we are lucky enough to have him back in India, Dr. Kiran More. So welcome, Dr. Kiran More, and he is one of the host. I would he is a part of the whole this program that we have been doing since for last 1 year, and all these batches we have been training. He is now heading NICU unit at MRRCH, that is Children's Hospital. That is a kind of international branch of hospitals for 6 children, which is a very renowned hospital in the top 5 ratings in the world. He has been trained by prominent people in the neonatal hemodynamics like Patrick McNamara and all those people who have of international fame. And this, like, if I would introduce myself, the only thing is same teachers have trained both of us, so we are from the same this thing. I would request, please take it to back to the Dr. Kiran More's slide. And he has done his all his degrees from outside, and presently he is in India, but he was at Vadia, he was at New Zealand as a consultant. He has been working there, and then after the New Zealand he was working at Qatar, Doha, and there he has been running this program, similar program there. So, and he has an n number of publications and his literature. All those who join the group, all the papers, 500 papers you will be getting is basically his efforts that you will be getting the whole papers. So welcome Dr. Kiran, great to have you, and great to have you as a team member, as a partner, as a host, and everything.
Thank you for the opportunity.
And then next slide, please. Yeah. So then we have Dr. Kamal Arora. Dr. Kamal, if you are there. I can see. If you can just switch on your camera, please.
Yes, sir. Sure.
Yeah. So
Yes.
he has been in the first batch, but he has done his DM from AIMS, and presently he is the professor and head of neonatology at Department of Pediatrics at Dayanand Medical College, Ludhiana. I've done my post-graduation from Ludhiana, so we are same college. So he is being trained and been in this for the last around about more than 8 years, and we've been conducting the workshops all together. So he will be very aptly showing you how to optimize the image. So welcome, Dr. Kamal.
Thank you,
Great
sir.
to have you.
Can I add one line?
Please.
Even though I have done my DM, with due respect to all, I've done my DM there, but I've learned echocardiography and hemodynamics from you and your whole first batch. And I was privileged to be the part of first batch. And thank you for giving the opportunity, for taking out the time with us and doing so many sessions along with us in the National Neonatology Forum also. And the best part of this training was that you gave an opportunity to all your juniors to be a part of the workshops, and they can conduct there. And all the material is given to us with the whole life. I think that's, I always revise, keep on revising. I do it, I keep on revising. So currently we are doing 2 theses with our MD as well as fellows on SVC flows and our outputs with IVH, and also the lung ultrasound with the preterm. So thanks, sir. That actually the credit goes to you actually. Thank you, sir.
Thank you very much. And maybe have the next slide, please, for Dr. Anke. Yeah. So we have, yeah, we are going to start. 12:15. In the next 5 minutes, we will start. So we have Dr. Ankit along with us, who has done DM neonatology from PGI, and he is being working at Rani Hospital, Ranchi. So he has a number of publications, and he's was attending our workshops, and now he has attained the mastery in the point of care ultrasound. So Dr. Ankit, welcome. We welcome you, and he will be taking the sessions of head ultrasound. Welcome, Dr. Ankit.
Thank you, sir.
Dr. Sujit, if you are there, please, you can please switch on your camera, please. Yeah, so we welcome Dr. Sujit Kaur. She has done her fellowship in neonatology, and she is being heading and owning a unit, which is a big neonatology unit at Jalandhar, Punjab. She was again a candidate for our first batch, and now she has worked up so well and has been doing a great work in neonatal hemodynamics and POCUS. So we are lucky to have her, and her special interest in lung ultrasound. So we welcome you, Dr. Sujit. So we will have session for lung ultrasound from you. So now, I want to just reiterate that more than 1,800 registrations has been done, but we couldn't send the messages properly because of this WhatsApp issue. But now we will start with this very important topic, the basic principles, what are there at the backside, what we have been doing, the lung ultrasound, head ultrasound, and echo. Until unless we understand, we cannot go ahead with that. For that, Dr. Kiran More. So Dr. Kiran, over to you, please. Thank you.
Thank you, Dr. Mohit, and thank you everyone, all the faculties for such a great opportunity. And I'm astonished to see the enthusiasm. Then we were not prepared to get so many interest and requests, and about 1,600 people have really registered. I can see already close to 300 we are reaching now online, and I hope more people will join online and will record this session, and hopefully more people will get benefited. So again, as Dr. Mohit said, today's session is actually to stimulate you for or orient you briefly about the ultrasound, point of care ultrasound, and echo, and etc. It's too short time to get you oriented with all the details, but we'll try our best to stay touch base on all the points possible, whatever is required to be known in this field. And the teaching will continue there, and we can have more interactions, and we'll try to share as much as knowledge as possible. So my topic is kind of little dry, but it's very important that because I don't know what backgrounds different people are from. Some of you might be doing already ultrasound. This is just a refresher, but some might be new. And for them, understanding the basic principle is very essential. Without that, we cannot progress to the further sessions. And that's why we always start with this topic. And, we all are medicos, and we hate maths and physics, but this topics slightly touch base upon these topics which you don't like, but it's still very essential for us to understand, so that we can understand the echoes and ultrasound better. So I have got nothing to disclose. This is that beautiful MRR Children's Hospital where I'm currently working, and although I've used some of the videos from the NICU CD program, which was our actually manual or Bible when we learned echo about 12-13 years ago. So as Dr. Mohit mentioned, I was fortunate enough to get trained in the different sort of continent, and my first training was in Australia, and there was a systemic program of certificate of clinician perform ultrasound, and there was a very structured theory plus practical hands-on training, and X number of echoes we performed. And then I was actually fortunate to go and get trained formally for 1 year at targeted neonatal echocardiography in Canada. And so that was a training along with pediatric cardiology, so we could do a lot of structural training. And then we also, when we moved to Qatar, we started with along with Professor Samir Gupta and some of my other colleagues, we started programs called as Quinish, which was based on the lot of principles of the neonatologist performs echocardiography in UK. But what we try to integrate is all this learning from these different programs, and try to sort of available for the trainees to learn from. And similar program I ran in Wadia Children's Hospital where I was working. So people do get exposure from the pediatric cardiology and lots of functional echoes in the NICU, and then lots of theory, and I think that's the way to go about it. It needs a lot of dedication to learn this and to master it, and it's years of practice which actually makes you better. And now, as Dr. Mohit said, we have come up with this joint program with NfECHO Academy and the FOCUSin, where we are doing online plus hybrid training. So without delaying, my topic is very basic. So we'll just briefly touch base upon the ultrasound physics and what 2D means, what color Doppler, pulse rate Doppler, and some improvement in the image resolution. But I think Dr. Kamal will talk more on that. So we'll just stick to the basics. So historically, when the ultrasound was invented about 50-60 years ago, it was simple, like a B scan or an M mode. It was very simple, and it never used to take probably 5 minutes to do an ultrasound. But as we have advanced, we have progressed to have more and more advanced sort of imaging modalities from not only 2D but 3D, strain, spectral tracking, and all these advanced fancy things. And we try to gather more and more information. And but yeah, sometimes it gets too tiring, especially when you're learning and you try to do everything. It can get boring. So I think we should always start with some basics things, and then once you get basics right, go into the advanced modalities. Let me just try to get the straight of this my video. 1 sec. Right. So what's the principle of the ultrasound? As the name suggests, ultrasound uses sound waves, and it uses sound waves in the ultra frequency. So what is ultra frequency? So the frequency which are not audible to us. So lucky that we can't hear this frequency, otherwise somebody's scanning and we are hearing sound all the time. So audible frequencies are basically they are in the range of 20 hertz to 20 kilohertz. This is what we can hear. And there are infrared sounds which only special animals can hear, which like elephant. And then there is this ultrasound frequency which are beyond 20 kilohertz up to 200 megahertz or million hertz, which usually bats can hear, but we won't hear. So basically ultrasound uses this sort of range of frequency, and that is why the commonest sort of probes we use, or the megahertz probes we use, is around 2 to 12 megahertz or million hertz. So basically it is using the sound waves to produce the images. And how that works, so mathematically there are certain things we talk about when we talk about sound waves. Sound waves can be best represented by a sine wave. So as you can see how the sine wave look like, and the height of the sine wave is your amplitude, and the distance between the two waves is the wavelength. Sorry, yeah. And basically how these sound waves are packed depends and decides your frequency. If they're densely packed, you have a higher frequency, and it also depends on if you have a wider amplitude or smaller amplitude, how densely they are packed. So you have a shorter wavelength that can give rise to higher frequency because you can pack more waves inside in the same sort of a field. And the long wavelengths will have a lower frequency, and we will talk about how that differs. And generally the principle is that we need to have a higher frequency to get better sort of image quality, but again that has effect on it may not reach or there's a dampening happening, it may not reach the deeper structure. So sometimes we use low frequency to reach the deeper structure, but it might compromise the quality. But that's just the basic about amplitude and the wavelength. Now, how ultrasound was invented? So olden times, this sonar or the radar principles were followed by ancient ships and also in the aviation. And there's always this sound produced by the sonars. Basically, it's a kind of navigation based on the sound waves. And when the sound waves are going into the sea, if they're going into the water, there's no sort of signal coming back because there's nothing reflection happening. But the moment some objects comes, or a submarine comes, or a fish crossing, these, as you can see in the image, these waves get reflected back, and then you get a sort of signal that there is some object there, and an image of that object is formed based on the sonar principle. Similar sort of principle is used in the aviation as well. If the plane is entering in some territory, these radars are constantly sending the sound waves which go into air, then nothing is sort of detected, but some object comes and obstruct them and reflects them. Then you get a sort of a image of the object entering the territory. So the same idea has been used in the ultrasound principle, that the ultrasound machine or the probe of the ultrasound will generate the sound. It emits the sound waves very rapidly. It goes enter the system in the body, and you use the transducer to send these ultrasound signals. You hold it in the hand in a position, and it angle it in a way where your area of interrogation is, and then it will go through the various tissue or body organs or the tissue layers of the tissues, and it will get reflected as per the tissue density or velocity. So if it goes into the fluid, then there's no reflection, then it appears black. But if it touches some solid organs, it reflects back, and then you will see them echogenic or white. And so you can see here the sound waves will travel from the probe through the tissue and fluids. And sorry, this message is coming and obstructing the slide. 1 second, I'll just get rid of this message. Okay, yeah. Okay, I'm sorry there. So as you can see, the sound waves travel from the probe through the tissues and fluid, and there are different consistencies of the tissues which actually the sound waves come across. And as you can see, some waves will go through, some waves will go easily, they go through, and some waves will get reflected back. They will get reflected back. And then basically what happens is this transducer, which is a very smart sort of device which is invented, and it has got a lot of crystal. We'll see about it in the next slide. It is sending those signals, and how these signals are sort of reflected back. They again received in the transducer, and the transducer creates an image based on the altered signal frequency of the sounds. So this algorithm or the software computes the image based on the reflected sound waves. So this is, so what are these crystals? So again, you need to know, you don't need to know a dot of detail, but this word will keep coming whenever we talk about ultrasound, is something called as piezoelectric crystals. These are the elements, they are the core element of the ultrasound. And when the machine is turned on and electrical current is passed, these piezoelectric crystals will create a sound in the front of the transducer. And then this sound will go into the body and it will be reflected back. And you can see there are thousands of these crystals which are there attached to the transducer, and how these crystals are arranged. Based on that, these different types of probes are there. So, you know, why we need different types of probes? The basic principle is this, the arrangement of the probe, these piezoelectric crystals, and it depends on what you want to scan. So there's an array in which they are used. So suppose now normally we used a phased array probe for the echocardiography. Why? Because this even smaller footprint allow images through a small intercostal window. It can image the whole heart. So you can see it goes like this, a triangular way. So you can just go in any intercostal space at the apex of the heart or something, and you can still visualize the whole heart, the way the electric crystals are arranged. For certain scans like head scans and abdominal scans, you need a curved array probes. And for the lung ultrasound, some other imagings, you can have a linear array probe. So it is just the how the basically the footprint of the probe and how the arrays and how the sound waves are interrogated. These different types of probes are designed to interrogate different structures in the body. Now, whenever we send the sound waves, we basically the body does something to the sound waves, right? So there is an interaction between the sound waves and what tissue does it to it, and then that interaction produces the image. So so basically, again, this is the transducer. So some waves are coming. So you will get some waves will go all the way down without interference, and like if you interfere with a if they get interacted with the water or fluid or blood, then generally they don't get reflected. So that you get a blackening. So, you know, there's like fluid and everything appears black because there's nothing reflected back. But then some of them will get reflected. So they go down and they come back up. So there's a reflection happening. Some of them will get refracted. So they go and whenever they change the interface, they get deviated. So the angle changes, they get refracted. And they also get attenuation. So they don't reach in the same sort of frequency and intensity as they pass through the tissue. So as you can see in the high frequency also, you know, you get dampening. So as they go down, there is a dampening. So that is your attenuation, which is happening. And also they get scattering and absorption happening. So, you know, if they hit irregular surface, they get scattered in different directions. So your image quality goes down, and sometimes they get absorbed. So sometimes you see when you try to scan, you don't get a good image because there's scattering and absorption happening because you're not getting the reflected waves back to the ultrasound probe. And that's why your image is not good. And that is why we need to, you know, exactly learn where do we interrogate for which views and how we can optimize the images. So reflection, again, as I explained already, you know, it is the waves reflected back, and that is very essential for getting the images. All our basics are based on the reflection of these different tissues, and the amount of reflection depends on the differences in the acoustic property of the two tissues. So there is acoustic impedance. So basically, so common bright reflectors are the pericardium. Sorry. So you can see, so common is pericardium. So you see here the blood appears black because there is no reflection. There is a pericardium is appearing very bright because it's reflecting very brightly. Some of the other tissues will reflect little less sort of white. So it depends really on the acoustic impedance and the property of the tissue and how thick they are, or what is their property and how much they reflect. So bones and all will reflect a lot, or the pericardium, epicardium will reflect a lot compared to the soft tissues and other. Then refraction, as I again mentioned, why refraction one need to know. Refraction doesn't actually help much in the image formation, but it can actually deceive you sometime, because refraction is basically the bending. So wave comes and it hits an oblique surface area, it changes the direction. And what happens because of that, sometimes some artifacts can be created. So one has to be mindful that there might be refraction happening. So you're trying to visualize a vessel and there is a ghost vessel appearing next to it, which is an artifact. Sometimes you will see the lines which are actually in the UVC, but you will see them in the somewhere else, or the PIC line somewhere in the liver, or you see sometime outside the vessel wall, and that is just because of the refraction which is happening. So you will see images appearing which are not there, and that is very essential to know. And there are lots of artifacts I'll not cover in today's talk, but which actually can deceive you and you get confused when you start to learn scanning. And attenuation, as I already mentioned, attenuation is basically there is a decrease in the ultrasound wave intensity as it travels to the tissue layers, as they go to the deeper and deeper surfaces. So, basically, obviously, whenever sound waves pause, there's a loss of energy. This energy is lost because of the absorption and scattering. And then weaker signal goes into the deeper structures. As you can see in this image, so the basically at the beginning, if the waves are like this, then they slowly get down. So how do you get over it to reduce the attenuation? And it is very essential, and I covering this topic because higher frequencies will get more attenuated, and that is why they get less penetrated as compared to the lower frequency. So that is why when you want to do a deeper structures, you use low frequency waveforms. You reduce the frequency so that the attenuation is less in this kind of waves. But if you have higher frequency, the advantage is you have a better image quality. So always you try to image anything with a higher frequency. So that is your 8 to 12 megahertz. And especially for the smaller preterms, it works very well. They have thin chest wall. Attenuation is less. But suppose you have a bigger baby or there is some structures interfering, then you have to use lower frequency probe, or certain probes will allow you to decrease the frequency to reduce the attenuation and then get a better image quality. Again, these are all the practical tips when you start scanning. Now coming to with these basic principles, I'll move on to some of the basic ideas, what we basic sort of modalities of the ultrasound which we use. Again, Dr. Kamal will talk a lot on this image optimization, but it's very essential when you start scanning. You have to be a bit gentle to the baby and try minimally handle these babies. Don't be very enthusiastic and destabilize the sick baby. Starts with simple babies, which are stable in the NICU or in the postnatal ward, aware of the temperature. If required, use sucrose, dummy or something, to calm them. Sometimes you can ask the mother to stay and hold the baby, or the nurse to hold the baby. And this is very important when you start scanning, because, you tend to spend 20, 30, 40 minutes, sometime an hour with a baby. So at most important to take care of the baby. Again, there is a way to handle, and we will have more details about it in the next talk. But, it is important to learn how to hold the probe. You don't hold the probe like this or like this, but just like a pencil, and in a very gentle way. And then you have to position the patient very, very well so that the chest is exposed. Make sure your body ergonomics is good. And, there are these knobs which are there to help you to optimize, again, which we'll learn in the next talk. So this is how, how you hold the pencil. You hold the probe like that. And when in this position, you can do a lot of movements of the probe. So there is like a rocking along the long axis or on the short axis, or you can rotate, tilt, anterior tilt, posterior tilts, and all this we will talk in the demo session. Also, Dr. Mohit and I will be showing. We will demonstrate you how you tilt the probe so that you actually reach the organ of interrogation and the exact area of the interrogation in that particular organ you are scanning. Again, this is about 11, 12 years old photo of mine, but I think this is in New Zealand. But this is a very good position for scanning. You make like a V, so that your right hand is comfortable, your left hand is scanning for a right-handed person. And you can see ergonomically, my back is straight, my hand is very comfortable. So when I'm learning, I can spend like 20-30 minutes easily with this position. Otherwise, you're in an odd position, you're trying to scan from a different angle and you're tired, then your image quality goes down and you'll get frustrated. So I think, again, more about it in the image optimization, but make sure you are comfortable, the baby is there, there's nothing rush, there's no rush happening. You turn down the blinds, as you can see here, the blinds are turned down, there's a light is dim, and see this V which I have made, for the hand, and that's really comfortable for you to work. And yeah, turn off the phototherapy, otherwise your imaging will be different. No bright lights. Now performing the scan. So it is very important that every scan should be complete scan. I see like within no time, within 2-3 weeks, people start doing like this 2 minutes scans, a 5-minute scan. And it is very risky that you might miss out on a lot of these things. So especially there is no echo done prior, especially in the heart scan. One has to define the anatomy priorly. But if it's defined, then yes, you can do certain quick scan. But otherwise, always try to do the complete scan. You can do functional assessment, interrogation of the wall. You can look at the shunts and all those things. So this is what we're going to learn. But important is to have a systematic approach. So when you're learning, try to go through a serial sequence of scanning. So there's a sequential scanning we call about. There are different steps you follow so that you don't miss out. So when you're learning, try to follow the steps. Go from one view to another view, and there are different areas or there are different sort of structures or the things you need to interrogate in each and every section, and you go through slowly, sequentially. Then you will not miss anything, and you will learn also better. Okay, so don't be in a okay, I'm going to just look at PD only, this one. I'm just going to measure TR. I'm not going to look at anything else, because you will get surprised. You might be assuming something and there might be something else sitting there, and you will not find unless you have gone through the sequence. Now, I'll talk about the echo here now, and the other principles we will lung and head will be spoken in the different lectures. So performing a scan, there are only like these 4 steps you follow and this sequence you follow. So whenever I was teaching my fellows, I always used to say that don't do random sequence. Always do 2D followed by M mode if needed, then color, and then the Doppler. And we'll talk about all this, what it does means. But this is designed, the machines are designed, and the sequential scanning is designed based on that. So whenever you do a 2D scan, 2D is basically just to look at the structure. So you define the anatomy, you eyeball the function, how it is looking. Then you can do some M mode to measure the dimensions. So M mode measure helps you to measure the dimensions of the various chambers of the heart, etc., and compare different chambers of the heart. And then you put color. Then you just put a color to on different vessels or across the valves to know which way the blood is flowing, because you want to know it is going right to left, left to right, is a regurg, or all those things. So you just put a color, and then you would like to know what velocity this blood is flowing, and there are different pulse wave Dopplers and continuous wave Doppler to measure that. Okay, so you interrogate with a 2D, do some measurements, put some color, and measure velocity, and that's it. In every section, you go from one view to another. You go through this sequence. It will help you to sort of ascertain. So this is just an example of a parasternal long axis. You got the 2D first, then you put the color, and then you put the pulse wave Doppler and measure the velocity. This is how sequential scanning works. Not every scan doesn't require M mode. Very specific scans requires M mode. So this is how you follow. If you follow this in every image, you will now never miss anything. Now, M mode is something, is like, this is the first mode which was invented, as I said in the beginning. It's a B mode. Basically, what you're doing is you're cutting the heart in a particular section. So if you just like vertically cut heart in any particular line of interest, and then you plot it over the time, then that gives you different dimensions. So like here, you're cutting the aortic valve and the LA in one particular line, and it is in the same phase of cardiac cycle. So you can see ECGs here, and then you are comparing your aorta with your LA. So that's how M mode helps. It will help you to determine the dimensions of the ventricles, etc. So there are, again, you will see that in the different views. So M mode basically You can move the cursor in the area of interest, adjust the depth, adjust the gain, and then you freeze, and then you do the measurements. And you can see as here, the measurements are there. It helps you to ascertain different chamber sizes and make interpretation based on that. If there's a cardiomegaly or whatever, or if the LA is enlarged compared to the AO. So that's your M mode. Now coming to the Doppler principle. So so the Dopplers basically principles covers your color Dopplers, pulse wave, and continuous wave Doppler. So what is the Doppler principle? We already talked about ultrasound physics. Now the Doppler principle is basically John Christian Doppler in 19th century is an Austrian scientist. He proposed this principle, and this Doppler principle is used in those radars and sonars and which I already mentioned. So basically, he thought of an analogy of a ship moving to meet or retreat from the incoming waves. So ships coming toward the shore and going into the deep sea. So what he observed, that ship moving out of the sea would meet the waves more with more frequency. Those ships actually, they feel resistance, or the more waves are faced coming from the seaside as against the ship moving towards the shoreline. What does that mean? To translate into again a simple example
Kiran,
we often feel.
Sorry.
Hello. Yes.
5 minutes.
Just 5 minutes. Okay.
Yeah.
Okay. Sure. Okay. I'll just go through these principles only, and then I'll finish. Yeah. So Doppler principle. So if you're standing, a person is. So if there's an ambulance coming, the person standing here, an ambulance coming towards him, he will hear the siren of the ambulance very loud, because it is coming with a higher frequency, as against the person who's standing here and away from the sort of ambulance, the sound waves will be appearing in the lower frequency and will be less sort of loud. And similarly, the same principle applies in the heart when the probe is sending the signals. If the blood is coming towards the probe, the frequency will be higher, and if it is going towards away from the probe, the frequency will be lower. And then to make it the interpretation easy, the machine has color coded it, and then so the waves coming towards you, or the blood coming towards you, is coded as a blue color, and the blood going away is red color. Okay, and we'll talk about that in the color. So these are the different sort of principles of the Doppler we use. So color, pulse wave Doppler, continuous wave Doppler. Okay, and there are different sort of purpose for that. So now in Doppler, very important is your angle of insonation, because again, to get the best sort of frequency captured, your probe should be in the line of the direction of the flow. So if your vessel is here, your line of interrogation should be here. But a lot of time what happens is your probe vessel is here and your probe direction is at an angle, and that causes an error, because you're not actually capturing, it's like hearing that ambulance in the street or away from the street. So when you're away from the street, the sound will be less, but if you're in the line, your sound waves will be higher. So it's very important to have a perfect angle of insonation when you're scanning or doing the Dopplers. And otherwise it will underestimate the values. Again, this is an example how the same area, how these probe different direction, you can see these waveforms are different in the same area. So the way you angulate, the waveforms will differ, and you can underestimate. You cannot overestimate, but often you underestimate the velocities. That is why even a correct check technique is very important. So this is how the color Doppler looks like. So you're interrogating the flow of the blood. And as you can see in the same vessel, the blood going away will be captured as blue, and toward red will be towards. And then if there are high velocity, there is a turbulence happening, then you might add a yellow or green pixelate. So you will see some color changing, and that's called as aliasing. And you will see that how that color change will happen. So this is the simple color Doppler. You can see as you can see, the probe is here. See, the P mark is your probe. So you're seeing from here. So the PDA is red jet coming towards you, and that is red, and the blue jet is your LPA going away. So barred, blue is away, red is towards. And important is that you need to adjust the velocity of the color Doppler. That is also important, that you can see this same valve where velocity is dropping. And as you drop, you see the color starting to change here. So that happens because you have to be in a natural velocity of the flow. So basically, every structure has got a like the arteries have higher velocity, so you need to use higher scales. The veins have lower velocity, so you use lower scales. But most of the time, you will get away with using scales of 60 to 70. Again, we'll talk about that more in the practical aspects of it. And if you don't do that, this is what it happened. The color will not look good. It looks like, not looking red or blue. It looks like greenish oranges because you're not in the natural sort of scale frequency. Pulse wave Doppler. Now you want to interrogate and measure the velocity. So Dr. Mohit, I'll just take 2-3 minutes and that's it. Pulse wave and CW, and then I'll finish. So pulse wave is important to integrate the blood flow in a specific location. So like here, you are interrogating it across the mitral wall, or you can interrogate across the pulmonary valve or any area of interest. So you put a sample gate around that area, and you measure the scale. Now, issue is that it uses single set of piezoelectric crystals for sending and receiving the signal, and that is why it has a limit. So you adjust the sample gate in the area of interest, but the problem is because the same set of crystals are utilizing it, there is a limit to the pulse wave Dopplers, which is called as NiCU limit. And so that is something called as pulse repetition frequency. But just for practical purposes, PW has got a limit, so you can interrogate all structures with pulse wave Doppler with the area of interest. But beyond certain scale, if the velocity is very high, pulse wave Doppler will not pick up those velocities because of its intrinsic NiCU limit. But it is very accurate in determining exactly the location and measure velocity, so you'll know exactly what's happening with that particular point. But as I said, it doesn't capture all the velocity, and that's why you need continuous wave Doppler. So here, just an example, how the pulse wave Doppler looks. So your red jet will be above the baseline, and the blue jet will be below the baseline. So this is blue jet, which is below the baseline. So your blue is red, blue is below the baseline, and the red will be above the baseline. This is how the pulse wave Doppler will look like. And if you just, this is just an example of the NiCU limit. So if your scale goes up, the PW will not be able to capture. So if you see here, what is happening beyond particular point, the scale will alias. Okay. So this is called as aliasing. It will not capture everything what is desired. And so then you have to do some adjustment when you're doing the pulse wave Doppler. So if you have a bidirectional shunt, you keep the baseline at the center. But suppose you have a vessel coming, like the flow is below the line, you might have to adjust the baseline above, or if it is above, then you adjust the baseline here. So see how the baseline is shifted in pulse wave Doppler. Okay, and the last but not least is the continuous wave Doppler. Running short of the time. So continuous wave Doppler basically uses two different sets. The difference is it has got two different sets of piezoelectric crystal, one for sending and other for analyzing. And that's why it has a capacity to reach sort of a maximum velocity. It can go up to 2 meters, 3-4 meters per second, and there is no limitation of pulse repetition frequency happening, and there is no NiCU limit. And that is why it is good for measuring higher velocities like tricuspid regurgitation, coarctation, etc. But disadvantage is that it is not possible to determine the location because the signal is noisy. You don't know from where it is coming. So as you saw in the previous PW, it was just a small gate. Here, it is measuring all the velocity across the line. So it could be anywhere. You don't know from where these velocities are coming. Any velocities coming across that, all that line will be measured. So that is why, again, the limit is there, but a lot of time we know what we are measuring, so it's not that difficult. So tricuspid regurgitation, aortic coarctation, pulmonary, all this pulmonary stenosis, all this will be captured in the continuous wave Doppler. So just a demonstration how this is captured. So let's say this is just the video. So basically, you're capturing the continuous wave Doppler here. I'm sorry, I think the video is not playing. So basically, yeah. Yeah, so you can see the line is across the pulmonary artery. There's a stenosis, and you see this baseline we have adjusted up, and you see a high velocity like up to 300 centimeters per second or 3 meters per second, which is captured. And there is some additional false velocities are also captured, which is commonly you see in the continuous wave Doppler. And I'll skip this different turbulence patterns. And I think we will talk about these estimations of the gradient patient and the VTI in the upcoming talks. So I think I will stop here. There are additional majority modalities are there, which I think is not the interest for the today's CME, like tissue Doppler measures the velocity of the tissues, not as compared to the blood velocity, which you measure in PWCW. And there are different strain spectral tracking, which again helps you to analyze the segmental movements of the or the function of the heart, which is again probably we'll do it in advanced CME, not in today's CME. With that, I'll stop. Don't forget the basic rule of doing 2D followed by M mode followed by color and PW or CW when you're scanning. Thank you.
Thank you, Dr. Kiran. It was really simplified and you very well completed in time, just overshooted by 5 minutes. And that was a real great effort to do that. I know it's a big problem, but it is very well covered. So again, I would like to apologize now, like while we have started, 60 people have already registered, but we have closed because now it is not possible to send the links and everything to them. I would request people in another 1 minute, if they have any issues, they can just please write in the chat box so that if there are any questions, we can just clear the doubts. And then we will go to the next session. While we are doing that, I'm just trying to reiterate that if those who are interested in learning neonatal POCUS or echoes, we have been running our online and hybrid. There is online plus physical hands-on courses of 6 months certified courses, registered, verified by Government of India. If you are interested, you can just send a message on this WhatsApp number or send us a mail on nfecho2505@gmail.com. So for our next session, now whatever Dr. Kiran has just talked, that we will do the live demo, and that will be done by Dr. Kamal Arora. So he will be doing the live demo, that how to adjust the knobs on the machine and how to optimize the your views. So I would request everyone that on your screen you can pin the device with the name Dr. Kamal Arora, so that it will be staying in front of the screen. And I would request the sports staff to pin Dr. Kamal Arora device on your device also, so that it gets recorded in that format only.
Yeah, just some people are commenting
online courses,
audio is less.
Send the Is
Dr.
it okay
Mohit,
now?
I think the audio is okay, for
Yeah. Okay, audio is
so
okay
people,
now,
please check devices. I think the audio is fine and the network is okay. So please check your sound of the device. I think the audio was okay for everyone else.
So,
Yes, sir.
More questions will answer.
While he's been, Dr. Kiran, there is one question. The color box.
Yeah.
The color box, Dr.
Sir, I'll explain.
Kamal.
Yeah.
While you
Dr.
will be
Kamal will explain the color
demonstrating,
box, how to adjust, and maybe even angle of intonation probably. Yeah.
Yeah, angle of intonation and color box. Can you just explain them while you are doing that? Thank you.
Yes, sir. I'll do that, sir. Okay, should I start, sir?
Everybody, please pin Dr. Kamal's video device, and the sports staff, please pin Dr. Kamal device so that it will get recorded, and if anybody speaks, it does not change. That is very important.
Yes, sir. Should I start, sir?
Yes, please.
Okay, sir. I'll pin this. The camera will be facing towards me, the baby, and the machine. So we'll keep on changing little bit. If there is a network issue, please let me know at that time. One thing. Second thing is I'll switch on the machine, everything from the start now. Right. So my fellow will be holding the phone, sir, and facing towards me. Am I audible, sir? And seen?
Yeah.
You can come. Fine, sir. So, good afternoon, everyone. After a wonderful lecture by Dr. Kiran, I'll take 25 minutes maximum half an hour to explain you the basics of the machine and what Dr. Kiran has said in the practical demo. Fine. So, there are different types of machines which are available. We have a Sonosite machine, we have a GE machine, we have a Philips machine, we have nowadays a Minray machine. So the basics, what I want to tell you, the basics in the machine remain the same. So don't worry which thing you are buying. The basics will remain the same. We'll talk about that basics in this machine. So this machine is a Sonosite machine which is available in our hospital. And once you start with a machine, there are three parts of the machine. This is the motherboard, which you keep on. This is the extender where you connect the probes. You have the probe at the end. You can see the probes are connected over here. I can show you the machine, and this is connected again over here. And the another and the another. So there are different types of probes which Dr. Kiran has already told, and there's a printer. Okay, sorry for that interruption because it's a phone. So then there is a printer over here which prints and gives you the more medical legal. I would say the issues with this are solved. Sorry. Okay. So once you connect the machine, please connect the machine to the UPS. We have connected the machine to the UPS, and don't allow the machine to close on its own. And never shut the machine once it's working. Never shut the machine like this. Please switch off the machine. Please switch off the machine and then close it. So I'm just switching on the machine. So this is a switch on button on the machine. So this is now getting on, and it takes some time to on itself. So you can see there are lines moving, and it is just showing you that this is getting on. So once this is on, what happens is there's a data which is being retrieved. You can see, just show over here. You can see there's a blue line moving over here, and the data is being retrieved over here. Till the time the data is retrieved, you can't store any image other than this. Fine. Okay. After this, you enter the patient data. Please don't forget to enter the patient data. There are 4 buttons over here. Setup. What setup has been done for the machine by the administrator, by the company. There's a report over here. You generate a report, review the data, and then patient. So first of all, you enter the patient data. I'm pressing the machine here, and what you see is coming over here is the patient data. So this was a earlier patient, so I press the new button over here. So it is taking its hourglass time. You can see this. So it is saving the previous data and allowing you to enter the new data. So for this baby, like I'm keeping the name of this baby is Mahira. So M-A-H-I-R-A, Mahira Sharma. Please don't forget to enter this data. The ID, I'm adding an ID 1, 2, 3, 4, 5 or 6, whatever the ID is. The date of birth, the gender, all the things have to be added here. Female, the user is me, and the exam type is the cardiac. So you have to tell the blood pressure, the heart rate, weight, height, everything has to be recorded here. So currently the heart rate of the baby is 149. So when I started, it was 149 because you have to calculate the cardiac output, many things. So you enter over here. The reading doctor is me, Kamal or Dr. Mohit. Then the department ID, then you are done with it. So whatever is written over here, you press this button, it will be done. So we are saving the data at this point. So this is hourglass which is coming. So it will save the data, and the screen will come up now. So if you save this data, so this is Mahira, this is the ID. We are doing on 3rd December 2023. At this 1-2 time, the probe is the cardiac probe, and these are the MI is the mechanical index, the thermal index are there, and you will save this data. So if I want to review this, I'll just press this button, review. Just show over here. So I'll press the review button. What comes over here is all the data which has been stored here. So if I want to retrieve the baby of Kajal, so if I press over, or maybe this patient I had earlier also done for this patient, Mahira, then you press review. So there comes 4x4. So I have saved 4 images of this patient, and this is a 4th. So if I go This is the third image. This is the second image. This is the first image. So I have saved these images till now. Fine. So I'm going to do this for this patient Mahira Sharma 1, 2, 3, 4, 5, 6. This is totally a new patient. We are not showing that this is a patient. So once you start with this thing, you have the different modes. I'll complete this machine first. You have the different modes: the 2D mode, the color mode, the Doppler, and the M mode. Fine. Then there is an exam mode. What exam you are doing? So if I press the exam mode, there is the point which will come over here is cardiac, neonatal, and the abdomen. So what I am doing actually here is the cardiac today, not the neonatal and the abdomen. But if I want to do the abdomen, then we'll do the abdomen part here. Fine. Okay. So this is done, the cardiac part. Then you have different points over here. One says the clip is being saved, the video is being saved. You freeze it and then see it. We'll do this here. Then the calipers to measure, do the measurements, pre-existing calculations which are already there in this machine. Then the audio gains, auto gain, and then the different gains. We have already talked about the gain, and these are the buttons which are actually there to adjust the gain. Here is the QWERTY keyboard, which actually is like a computer. So you have the caps lock on, the tab, the shift, everything is there. Don't rotate. Everything is there. So you can enter the data from here. Fine. Whatever is written here, these are all the buttons which show here. So if you want to go to page 1 and 2, you press over here. So page 2 shows this. Page 1 shows this. If you want to do the sector dual, so there will be 2 sectors over here. If you want to decrease the sector, then this is done. So there are different modes will come across these points. So now should we start and see how we do the image, and then how do we get it? One thing more, some of you have asked the question that how to clean this board. Please don't put chlorhexidine or anything on the motherboard. Otherwise, it will all go off. There will be short circuiting and everything will go off. You will be actually gone with nearly 5 to 6 lakhs for correcting this motherboard. So please don't clean with this. Simple cotton can clean this thing. And if you are taking up this probe, so we have talked about the probes. So this probe is the phase array probe. Harmonic probe phase array measuring from 4 to 8 hertz. This one, 4 to 8 hertz. And this 4 to 8 hertz is written over here. I'll show it. So I've removed this probe here from here. Yeah, this one. So you can see 8 to 4 hertz. So it is written over here. So whenever you are doing this 4 to 8 hertz transducers, fine. So from the Fujifilm Sonosite, this is what they have written from the USA they have modeled. So once you fix it again, you have to fix it very nicely, because don't remove it again and again. That's why the extender is there. Fine. And another probe is this one. This is the linear probe. You can see. So the piezoelectric crystals are placed linearly over here. And this is written 6 to 13 hertz. So it is a higher frequency probe, measuring from 6 to 13. So it will be used for the superficial structures, where we'll get a better resolution but lesser penetration, as Dr. Kiran has already told you. So this will be used for the vascular, for the central lines, for the lung ultrasounds for the baby. And this will be used because 4 to 8 hertz for the heart ultrasound for this baby. And this can also be used for the cranial ultrasound. Fine. So you need these 2 probes, and this probe also comes as a hockey stick probe. We don't have with this machine, but it's available with the Philips machine. Hockey stick is almost like a linear with a higher frequency than this one. Fine. Okay. So currently we are doing with a phase array probe, which measures from 4 to 8 megahertz. Okay. So let's start with the probe cleaning. First of all, the probe cleaning, because this already has a jelly, it means it has been used for someone else. So what we are using is we clean it with a chlorhexidine, and I put the chlorhexidine over here and I'm cleaning it over here. This part. Fine. So this has been cleaned. So this is one. I throw it over here. Use another one. Only a single go and then clean it. Fine. Okay. So once the probe is clean, you put a jelly over here. Do slightly pre-warm it if possible, or you can pre-warm over here. Fine. So just pre-warm this jelly. These are the basics actually. The basic precautions, the hand cleaning, I put the gloves. So do that one. And what I usually do is I put because otherwise it aches your hand. So what I've done is I put over here around my neck, selected the probe. I selected this probe. Okay. So this probe is done, selected, and we get a sector over here. Fine. Should we start with this, the baby? Okay. So first of all, what view we are doing is the, I'm not teaching the views, I'm just putting the probe or the views, and then we will do the optimization. So whenever I put a machine, probe, like this is an apical view, Dr. Mohit will tell you better in detail. I put over here, now you see the screen. Okay, sorry. Before that, I forgot. This is the probe indicator. So this is the probe indicator, the point which you can see. It can be a light also, it can be a line also, it can be this small dot also. This indicates the site like this. If I keep on the right side, on the image, you can see this point. I think everybody can see. So this is the same as this one. So this side is the same. If I keep it like this, so this side will be shown here and this side will be shown on this side. By convention, I keep this on the left side, and on the image also it is seen on this side only. Fine. So if I change the probe, you will see that this changes over here. So if I change the transducer, to the other one, so now you see this has changed on this side. So this is a linear probe. This is by convention actually. So this is a probe indicator over here in the linear probe, and this has changed to the other side. This is by convention actually. You can always change from this side, upside down, everything can be done over here. Fine. So I'm going back to the phase array probe. So now we are changed again. Do buy this extender whenever you buy this sonoset machine. They give you a separate, and this costs you like 1 to 1.5 lakhs. So do buy this extender, otherwise you have to keep on changing the probe over there. Okay. Once I keep the probe, you can see this heart is seen as very small, and this area is seen as very big. But my area of interest is the heart. So if I want to see the heart, what I'll do is I'll increase the depth. So now what is now happening is the image is seen better. You can see this one. So there's a difference between the two. I'm decreasing the depth. It starts like this. My area of interest is here. So I have to go increase the depth. So now I can see all the 4 chambers over here. So I can see all the 4 chambers over here. So this is one chamber, this is another chamber, this is another chamber, this is another chamber. Fine. So this is like image optimized. If I keep it like this, still the chambers are seen, but it is not in the center. Fine. And something is happening, but I don't know what is actually happening. So if I keep like this, it will go other way around. So I have to keep the image in the center, and my area of interest should be lying almost in the middle of the screen. So if I'm interested in the mitral or the tricuspid valve, they should lie in the center of the machine. Am I clear in this part? Okay. So let's go ahead. So as Dr. Kiran has told, once you optimize the image, once you're done, then next you use either the M mode or the color mode. So if I press the color mode, so now the question comes up. Okay. Sorry, before I go to this color mode, there's another thing which you need to remember is the gain. So gain, there's a gain button over here which shows the auto gain. Auto gain means if I press this auto gain, the image comes like this. Other way around, some machines have, so this total sector is divided into 2 by this machine, but sometimes it is divided into 8 or 7 parts by the GE or other machines. So if I decrease the gain over here, so what is happening is the total area is, the gain has decreased. So now the gain has.
How to bring the image in the center. Yeah.
How to bring the image in the center. Okay. So I'll go back before I do this. Okay. So you can see over here. So now what I'm doing is this image will be shown to you by Dr. Mohit also. I've kept the image over here, my probe over here, and the pointer is on the left side. So now you see the image on the screen. It is not in the center. Okay. So now you see again what movement I'll do. I'll go to the slightly towards the lateral side. And now you see the image, what is happening? It is come in the center. If I go further, now what is happening is image has gone to the other side. So I come back and keep in the better. So this is how this is the point where you keep the probe, like at the Dr. Mohit will teach you that you keep at the nipple. So that image, the views will be shown by Dr. Mohit, but you have to keep that area of interest in the exactly in the center. Fine. So now then coming back to the gain. So if I decrease this gain or increase this gain, so what is happening is more white. So I'm getting better echoes from there, but my image is getting blurred. So I don't need this, and I also don't need this. Fine. So this is decreasing the gain, this is increasing the gain. So I need to optimize. So one button is auto gain. Some machines show this button as eye scan. Eye scan means auto gain. So press that one. So if I do this here, you just show this one. So what this shows is the upper part will be increase or decrease, and lower part will remain the same. So what I'm doing is increasing the gain here and decreasing the gain here. Fine. On the lower part, you can see increasing the gain in the lower part and the upper part.
What is the optimal?
So what is optimal? Optimal gain depends upon which area you want to see and what structure you are seeing. So if I want to see a calcified mitral valve, so I need to decrease the gain because the calcium will be shown like exactly the same. Because calcium is hyperechoic, it will be shown if I decrease all the gain, but that calcium will show me the better. But if I want to see a structure which is barely seen, I want to see a thrombus or something, then I will increase a little gain or press the auto gain so that it optimizes, the machine optimizes itself. Okay, close it. Okay, that is one. Now pressing the another button. So we did the 2D image optimization. Remember that it has to cover the 60% of the total screen. Area of interest should lie in the center and the gain has to be optimized. The depth has to be optimized, the gain has to be optimized. Fine. There's another button which I'll tell you is a zoom button. Okay, the zoom button. See this zoom button. Zoom button is like you press this zoom button and area of interest where the center is will be highlighted and this will come up like this. So if I'm seeing a coronary artery and I'm not able to visualize, I'll zoom that part. Zoom, press zoom again and you will go back. Fine, that is zooming it. So you know the zoom, you know the auto gain, you know the depth, you know the gain itself. So now that is about the 2D. See. Okay. Then coming on to the next is the color button. So I press the color button over here. Now what you see is some colors coming up over here, a blue and a red color or some other mixing colors also there. And you can see the color scale. So color scale depends upon the velocity through which the blood is going. So if the color scale is like 78 to minus 78. So plus 78 means it is coming towards me. Minus 78, it's going away from me. So the blue is away and the red is towards. That is the mnemonic which Sir has told, Dr. Kiran has told you, is a BART. B-A-R-T, blue away, red towards. So this blue is negative and red is positive. Fine. So I have some colors which are seen over here, which is red, which means he is showing the knobology only. Okay, yeah. So this is the red, which is coming towards me, and red going away from me. Me means the probe. Probe is lying over here. So the probe is here. Remember that. The probe is here, this point, and the color is going away from me. So something is going away from me and something is coming towards me. Fine. Am I clear in this part? Okay. So that is basically the color. Now, what Sir has told you, if you decrease this scale, so I'll decrease the scale. Fine. Just see it. I'm pressing the scale button, going down. 78 will become 64. Now I'm going down. Now it is 56. Going down. Now what is happening is 44. Now going down, it is happening is 36. So now you see the colors have all distorted. Because it was a high velocity. Yeah. The question is, what is the ideal color scale? It depends on the velocity of that, the blood flow in that vessel. So if I was doing for this aorta, now you just keep on seeing this sector. I'll increase the scale further. Now I'll go back. Go back means I'll increase the scale. 56, 64, 78. You see the colors are better now. So it means the velocity was very high and I was not aiming at that velocity. If I do this for a pulmonary veins, which have a low flow, I'll show you the pulmonary veins. So if I have low flow, I'll not be able to see at a high velocity. I'm not able to see the pulmonary veins. So pulmonary veins have to come over here. Fine. So what will happen is I have to decrease the scale. Then you will start seeing this. Yeah. Now you will start seeing the pulmonary veins entering over here. But if same happens with the cranial. The cranial, the flow is very less. So if you keep that very high, So like for this baby, this is a cranium. Sorry for switching on from the cardiac to this mode. So this is a cranium. If I want to see the color over here, and it is 64, I'm not able to see the vessel. No vessel is seen over here. Fine. But if I switch on to this part, if I switch on to the lesser velocity, this will come up. Now you'll see. See, you are seeing it better. So you should know the velocity of the blood in that vessel. Fine. So coming back to the echo. Okay. So now this is all distorted. Going back, optimizing scale, optimizing the depth. Okay. Okay. Now comes the Doppler. So we have done the color Doppler. So this is not right. Now comes the Doppler. So what happens? You press the color. You have seen that there's a velocity going over here. This is actually the aorta, which sir will show you. I'm showing the inverted image. So you can see the aorta going over here. I put the color. This will be blue in color because the aorta is going. Now my probe is over here. Because the blue is going away from me, I put the Doppler over here. So now this is the Doppler, which is, everybody knows this is a pulse Doppler. This is a pulse Doppler. So Dr. Mahek is showing you this is a pulse Doppler and you get a pulse Doppler gate. Fine. So if I keep the flow is going like this and my Doppler is something like this, so what is the angle of inclination? To be nearly 30 to 60. So I need to get it aligned with the Doppler. Fine. So I am trying to make as low angle of incidence as possible, trying to make it nearly zero, but obviously zero is sometimes not possible. So I'm trying to optimize the image. And I'm inside the aorta. So once you press this pulse Doppler again, once you press this Doppler button again, so you'll get some waveforms. So this is because this was going away from me. This was going away from me. So what I'm getting, it is a line which is zero. Below the line and the velocity is something like this much. So the velocity is nearly 104.3 centimeter per second. So you can see 0, 30, 90. So this is 104.3 centimeter per second. Fine. But if I have a flow which is very high and my velocity is crossing 2 meters per second, means crossing more than 200, so I'll not be able to get the flow. So what I'll do is I'll switch on from the, so this was the color. So this was the pulse wave. I'll switch from pulse wave Doppler to the continuous wave Doppler. Continuous wave Doppler is shown like a diamond, or it can only be shown by a single line. Fine. So once I press this one, so it takes along whole line, whatever the highest velocity is. So you are getting better trace over there. Still you're getting trace over here, but you're getting a better trace with that one. So what we need to know is the velocity through that, vessel actually. Fine. So if the velocity is less than 2, the better is to use the pulse wave Doppler. Pulse wave has a pulse gate, whereas continuous wave doesn't have a gate. Fine. So for this baby, we have done the 2D, the color, the Doppler, and we know what the angle of incidence should be along that line. Then we have the M mode. So M mode is usually done to see the measurements. So measurement, like you can do LA ratio, you can do the ejection fraction. So for this baby, I'm trying to make I'm trying to optimize the long axis. So this is the long axis. Fine. So if I press the M mode over here, and I'm trying to measure the LA ratio, I'm not showing the technique, I'm just telling you the measurements basically. Before going into any mode, the 2D image has to be optimized. Yes, but yeah. So I'm pressing the, I've done the M mode, but I don't get better image. Yeah, better. Still lacking over there. So no. So image optimization is actually important.
Hello, Dr. Kamal.
Hanji sir, sorry, how much time?
Over 5 minutes are
Oh,
over.
5 minutes are over.
Overshooted,
Sorry.
yeah, we overshooted the time.
I thought you will remind me. So you can do the measurements. This is the last part. So you can do the measurements over here. One, fine. That is one. You save this one, and then you can do for the other one. Fine. But if there are pre measurements, so you can always see LA ratio is written over here. You can do LA ratio. You can do the ejection fraction. So they are showing ejection fraction is calculated over here. So this is the basics of 2D color Doppler M mode, and you have to keep on saving the image. So last thing, I'll just tell them how to save the image. So for this baby, like I'm trying to save the clip for this baby. So this is the clip. I press the clip button. So my image will be stored and it will be shown over here. So once this blue color is off, it means it has been saved. So it is still saving because it's a clip. So it is saved now. Fine. So if I want to save this image, so this baby, fortunately, unfortunately, has a PDA. So you can see this red flow, which sir was showing you, Dr. Kiran was showing you. This red flow is the PDA. Fine. So I'm not going to details of it. Otherwise, Dr. Mohit will say me. So I am trying to save the image. I saved the image. Now I am trying to do the Doppler for this baby. So what is happening here is this is aliasing, which sir was showing you. This was aliasing. So let's optimize image further. Still the aliasing is happening. So what we do is we can switch over to the, now this is a better image. Actually, it's almost there. So this is the PDA, the left to right, and below it is a right to left. Fine. So I save this image again. So now if I go to the review, I can see I saved 3 images, 1, 2, and another is a clip. So I press the play button. So it will show me the clip over here. I can generate the report from here, this machine, and I can take a printout from here. So now this is saved. Fine. So I'm not doing the echo now. This is just a saved image, which you can see. Fine. So if I want to print out of this, I'll just go to the print and press the print. So this is the print, and you can paste it in your file, and you can write the findings over here. Clear? Any questions? Sir, I think that is okay for this class.
Yeah, that's very nice. That's great. It was really a very nice and precise demonstration of all the things.
The last thing, once you finish it off, just with a warm cotton and this, you can clean the baby. You should clean the baby, I mean to say. And clean the probe also. So this is with the chlorhexidine. And then keep it back. Now switching off, last switching off. You press the freeze. It should be in the 2D and the freeze mode. So I freeze it. Now you press this single and this will switch off. Don't press it like this. Otherwise, believe me, your machine will go off in next 1 year or 2 years. So keep on, if you keep on doing this one. Until the screen gets off, please don't shut it down.
Thank you. Thank you, Dr. Kamal. So he has been demonstrated all the practical aspects that has been discussed by Dr. Kiran. There are few questions regarding here. I would request Dr. Kamal that in chat box, please answer those questions that are already been there, because it is really difficult to answer. It will take more time and we have already overshooted by 10 minutes. Okay. So we will go for the next talk. Our next session, before going to the next session, I will just share this program. I hope everybody is able to see the screen. So the next section is by Dr. Ankit, who is at Ranchi at Rani Hospital. He has done his DM from PGI and he's been doing the POCUS point of care ultrasounds from quite a few years. So basic normal views of the head ultrasound. After this session, we will go for the live demo of the head ultrasound views. And again, I would like to just tell if those who are interested in 6 months courses, they can either WhatsApp on this number or you can email on nfecho2505@gmail.com. The 6 month certified courses are Indian government approved. So Dr. Ankit.
Sir, there are some questions. I think they are all related to the calculations, how to make it in the center. I think that's all about image optimization. You will keep on learning. See, I'm telling you in 20-25 minutes. So you have asked a question like diamond कैसे रखना center में, वो image कैसे optimize करनी है.
English, Dr. Kamal, English. There are international people in the.
Okay. Sorry. So how to keep the image in the center, how to calculate the things, how to keep the diamond. I think this will require a proper learning, and this is just basics of it.
Yeah, this is the basics in the CME. In this CME, we have just stick to the basics. We will be doing either we can do the courses or we will be doing some specific issue based CMEs like PDA, PPHN and all.
Yes,
but again, it is very difficult to go into advance. It has to be a proper course. So that's why it is out of proportion to basically for this CME.
Perfect.
Thank you.
So thank you,
Dr. Ankit, please, and I would request you to just stick to the basic views and this thing, because there will be the questions regarding IVH hydrocephalus, but that will be again out of aspect of this basic workshop, a basic CME. So welcome, Dr. Ankit, please.
Yeah, am I audible, sir?
Yeah, you are audible. We can see your screen also, slides also.
Yeah, good afternoon, everyone. So I'm Dr. Ankit Ranjan, and in the next 45 minutes, we would be covering the basic views of the head ultrasound. So day out in the NICU care, you are using the term head ultrasound and you are getting adapt to the technology of the cranial USG. So why is it important and why do we need to know it? We are diagnosing pathologies which were previously kind of being detected late. This technology is giving us time to diagnose it in time and optimize the treatment. We often are determining the time of injury also, some bleeds and all. We can assess the neurological prognosis. So whole NICU care nowadays is kind of directed towards the neurological prognosis of the baby. So if you have a baby and you have a pathology you are dealing with, you can kind of predict how the neurological status of the baby would be going through in the future. A very important aspect is decision on continuation of NICU care. So we get babies who are extremely preterms. We get babies who are HI3 babies. Now, continuation of NICU care can also be kind of addendum to the cranial USG findings. And to top it off, the best part is that it's a non-invasive modality. So such is the importance of cranial ultrasound, and that's why we are discussing this topic. Now, neonatal brain sonography indications, if we look at it, there is a kind of constellation of things which we get day in, day out in our ICU care. So we get premature newborns who enter the intensive care, and these are at increased risk of intraventricular hemorrhages. We get congenital malformations. We get babies with seizures where we need to rule out certain things. We get babies who are on antibiotics, maybe in a state of meningitis, and we need to rule out ventriculitis. That we need to rule out certain TORCH group of infection, certain findings like calcification and all, which are very important, and whatnot. So these all indications, such is the constellation of indications that obviously kind of reiterates the utility of this modality. So without wasting further time, I would be starting with some basic parameters. So these are really basic parameters. And since the cranial ultrasound, we would be using certain terminology. it is very important that we go through or breeze past the basic patterns. Many of you must be knowing these things, but it's very, very important. So starting with the brain, we all know that brain consists of the cerebrum, cerebellum, and the brainstem. If we decode the cerebrum, we find that there is a frontal lobe, there is parietal lobe, there is occipital lobe, and there is temporal lobe. Now, dividing the frontal and parietal lobe, there is a sulcus which is called the central sulcus. And here, in between the frontal and parietal lobe and temporal lobe, so temporal lobe is getting divided from the frontal and parietal lobe with a fissure which is called the lateral fissure, or well known as the Sylvian fissure. So we would be getting these terminologies when we would be covering the basic views. So the Sylvian fissure is the fissure which is dividing the temporal lobe from the superiorly placed frontal and parietal lobes. Now, one of the major things which we come across in cranial ultrasound is the corpus callosum. So corpus callosum, if we cut open the brain in the sagittal section, so we would be finding in between is a vast kind of commissural binder. It's a myelinated axon collection which kind of conveys the left and connects the left and the right cerebral hemisphere. So this is the brain's largest commissural binder, and this we will be getting to see in the various sections when we discuss the different axial planes, all the planes of the USG brain. Now, at this moment, I would like to clear the fact that the planes, this is very important that we understand the planes where we are going to cut the brain to understand the basic USG views. So we have a coronal plane where we are dividing the brain vertically or longitudinally, where the brain would be divided into an anterior half and the posterior end. So coronal plane divides the brain into anterior part and a posterior part. Other than that, there is a sagittal plane where again we are dividing the brain longitudinally, but the brain is getting divided into two halves, essentially the left half and the right half. Okay, so coronal and sagittal are kind of 90 degrees to each other. Here anterior and posterior halves we are getting. Here we are getting the left and the right halves. The third plane, which very briefly we would be touching, is the horizontal plane, which is kind of 90 degree to both coronal and sagittal plane, and this is also called the axial plane. So we need to be very careful as to what plane we are cutting the brain, and then it would be very easy to understand what views we would be expecting on the cranial ultrasound. So looking at the corpus callosum, here is the coronal section. It looks like a cup shape, a moustache shaped structure. And if you recognize this, this is a lateral ventricle. We would be talking more about it. And it kind of crowns the lateral ventricle. In the sagittal section, it appears this greenish structure. It appears as an inverted C-shaped structure. Okay, so we would be getting this corpus callosum in and out in all the views of the cranium. The next most important thing is the ventricular system. So from time immemorial, from our MBBS days, we have been covering ventricular system, but it's very essential to again revisit the basics. So when we look at the ventricular system, if we look at from the front, we have two blue structures, which are the lateral ventricle. The sky blue thing, which is the foramen of Monro, is connecting it to a yellowish structure, which is the third ventricle. The third ventricle, again, through this red aqueduct of Sylvius, is going into the fourth ventricle. And this is replicated in this figure with labels. As I described the third ventricle, we have the foramen of Monro, which is leading into the third ventricle. The third ventricle from the cerebral aqueduct is leading into the fourth ventricle. Now let's rotate this ventricle and let's see through the sagittal section. So when we rotated the ventricles, what we see is a C-shaped structure with a tail to it. And this is the lateral ventricle. The lateral ventricle again opens through the foramen of Monro into a structure which is the third ventricle. The third ventricle again opens through the cerebral aqueduct or the aqueduct of Sylvius into the fourth ventricle. Now, one of the most important ventricles which we would see in many views of the cranial ultrasound is the lateral ventricle. So we need to know about the parts of the lateral ventricle so that we can understand the views better. So when we decipher the lateral ventricle itself has many parts. The first being the anterior part, which is the frontal horn, because it lies in the frontal lobe. So frontal horn of the lateral ventricle, this leads to the body of the lateral ventricle. Then you have a extension into the occipital lobe, which is called the posterior horn or the occipital horn. And then you have an extension into the temporal lobe, which is the inferior horn or the temporal horn. All the structures, the body, the occipital horn and the temporal horn meet at a common point, which is also called the atrium or the trigone of the lateral ventricle. This you would be keep on hearing. So the lateral ventricle essentially is having a frontal horn, it is having a body, it is having an occipital horn, it is having a inferior or temporal horn, and in the middle is the trigone. And this we need to know because this is very, very important. Now, when I started doing cranial ultrasounds, what I would get confused is that beneath the corpus callosum, always I would find a fluid-filled structure and anechoic structure, which I used to confuse with ventricles. But that's not the case. If you look at these pictures, if we cut the brain at the midline sagittal section, we are not cutting the lateral ventricle. So if we drop a sagittal section, we are not cutting the ventricles actually. Instead, between the anterior horns of the lateral ventricle lies a fetal space, a fetal fluid-filled space, which is called the cavum system. And towards the anterior aspect, this is called the cavum septum pellucidum. This cavum septum pellucidum itself extends posteriorly and is known as the cavum vergi. And the cavum vergi itself extends posteriorly, and sometimes you might be seeing another anechoic space here, which is called the cavum villi interpositi. So beneath the corpus callosum in the midline sagittal section, whenever you see an anechoic space, it's not the lateral ventricle, because lateral ventricle by name itself are stating that they are lateral. Okay, so you would be seeing a fluid-filled structure from anterior to posterior. They are cavum septum pellucidum, they are cavum vergi and cavum villi interpositi. So with time, they obviously fuse, and delay in closure can point to some CNS anomalies. Now, looking at one of the most important things which we discuss in probably asphyxiated babies or the babies with encephalopathy is basal ganglia and thalamus. So when you look at the lateral ventricles, just lying to the inferior of lateral ventricle towards the anterior aspect is caudate nucleus. So from when you locate the lateral ventricle, just inferior and anterior to it is the caudate nucleus, and lying just posterior to the caudate nucleus is the thalamus. So this relation, the lateral ventricle, the caudate and the thalamus, this is very, very important, and this we often kind of see in the parasagittal views, which we would be discussing. So lying lateral to the caudate nucleus and thalamus, the globus pallidus and putamen, the point of the basal ganglia. So if you look at HIE babies, hyperechoic areas which correspond with the caudate nucleus thalamic involvement are suggestive of poor prognosis. So this is very important. So looking at the basal ganglia part or the caudate and thalamus from a sagittal section, we have the lateral ventricle, which is denoted in blue here. We obviously discussed this. Lying at the top like a crown is the corpus callosum. Now, as I told that just inferior to the lateral ventricle towards the anterior aspect is the caudate nucleus, and just posterior to the caudate nucleus is the thalamus. So this is a very important structure which we would be identifying in the parasagittal views when we discuss further. So since we have revisited the basics, now it would be much better if we discuss the acoustic windows. So from where do we scan the brain? So neonatal brain gives us many windows to scan. Obviously, we talk about frontal fontanelle or the anterior fontanelle, which is the standard window. And this being a basic ultrasonography workshop, we would be covering the standard windows, which we cover from the anterior fontanelle. But there are some supplementary fontanelles, which are the posterior fontanelle, mastoid fontanelle, and temporal fontanelle, temporal window, which also can be an additive to the information which we find through the anterior fontanelle. So talking about the standard window and section, what we discussed is that the most important standard window is anterior fontanelle. We will be looking at some coronal sections and sagittal sections. So we have to be methodical. We have to locate the anterior fontanelle, and we have to document 6 coronal sections and 5 sagittal sections to complete our ultrasound if we complete the standard window. Okay, and supplementary windows maybe later. So when we are covering the coronal sections, we will see that the probe is held in the hand with the marker towards the right as a convention. While in the sagittal section, the probe will be held just 90 degrees to this, and the probe marker would be facing the mid face of the baby or the forehead. We will be seeing that. The probe, as we discussed, a sector or phased array probe would be preferable because of the small footprint, and 5 to 8 megahertz is kind of okay if we want to document the brain ultrasound findings. But if we are looking for superficial structures for a better resolution, 10 to 12 megahertz flat probes can also be used. Now, if we talk about echogenicity, we would be talking about anechoic, hyperechoic, hypoechoic, somewhere or the other. So to make it correct, this is anechoic. So anechoic is nothing but the dark black color. So from the surroundings, you can easily make out that this is dark black. Hypoechoic is kind of grayish in color, and as you see, gray matter appears gray. So gray matter would be looking like this, a grayish color, which is the hypoechoic color. Hyperechoic is kind of whitish color, and it kind of stands out from the background. So it will be looking pretty white. So we would be talking about these terms. Anechoic is the darkest black, which you can see. Hypoechoic structures would be grayish in color. Hyperechoic would be towards the whitish side. So let's start with the coronal views, which is the crux of this lecture. So the coronal views we are covering from the anterior fontanelle, and if we see the location of the probe, we have localized the the anterior fontanelle. The probe is pointing towards the right, and the hand movement, what we are seeing as the probe marker is towards the right, and the probe is getting tilted from anterior to posterior. So this movement is called tilting, and as we tilt forward, so we cut the brain across sections. So what we are talking about, the planes.
Brilliant. Brilliant.
Okay, sorry for the interruption. So we are seeing the tilting movements, and at this point, we would be seeing what the 6 planes do actually mean. So for the first thing, the first plane, which we can see here, is this plane, which is cutting across the front lobe of the brain, and this plane is called the frontal cortical plane, and this shows the frontal cortex. Okay. Simultaneously, if you look at the second thing, the second plane, it is cutting through the frontal horn of the lateral ventricle, and it is going down. So this is cutting through the frontal horns of the lateral ventricle. Further posteriorly, when we move, this plane is cutting through the foramen of Monro, which kind of is cutting through the lateral ventricle, third ventricle. It is cutting through the pons area also. Further moving posteriorly, we are cutting through the body of the lateral ventricle. So we already discussed that there is the frontal horn of the lateral ventricle and there is the body. So this time we are cutting the body of the lateral ventricle and some parts of the cerebellum also. The next plane which is cutting is through the posterior aspect of the lateral ventricle, and this is called the trigone of the lateral ventricle, what we discussed, where the body, occipital horn and temporal horn were meeting. And the last section which we see is passing through the occipital cortical area. So these are the 6 planes. And as we tilt from the front towards the back, we would be liking to document the findings on these 6 planes. Now look at the sagittal view. In the sagittal view, there are 5 planes. So you cut the brain, first of all, the probe position, as we discussed in the coronal plane, the probe position was towards the right. We have turned the probe 90 degree, and the probe position, as you can clearly see, is now pointing towards the forehead or the mid face. So starting from the mid sagittal plane, this is the first plane which you would be liking to document. The first plane which is going right through, where you could see the cavum septum pellucidum, third ventricle and other structures. Then if you tilt a little bit towards the left or right, you would be cutting the parasagittal plane. So both these are parasagittal plane, but in this parasagittal plane, you are cutting through the ventricle. So this is the parasagittal plane ventricular view, while this is the parasagittal plane where you are seeing the cortex. So you are not cutting through the ventricles here, you are rather cutting through the cortex. So if you look at both sides, you are finding that if you cover both aspects of the brain, you will be covering 5 planes. So 6 coronal and 5 sagittal planes. So let's look at the coronal views and gather what we have learned now and kind of look into the ultrasonographic picture of the same. So the first plane what we discussed was the frontal cortex. The line of our transducer was passing through the frontal cortical portion, and as you can see, it cut the orbit at this part. So when you see this, you get a ultrasonography picture like this. There is some whitish material here, and there is a kind of whitish line which is dividing the frontal lobe of the brain into 2 halves, and there is a hyperechoic structure which is nothing but the supraorbital ridge or the bony structure. Okay, so let's see the labels. So you have the interhemispheric fissure here, the frontal lobes, and this is the white matter, and as we discussed, this is the part of the bone, the supraorbital ridges. Okay, so interhemispheric fissure is nothing but the dura-mater lining which separates both the cerebral hemispheres. Now moving to the second plane, which we as discussed is passing through the frontal horns of the lateral ventricle. So you are cutting through the frontal horns of the lateral ventricle, and here is the temporal lobe of the brain. So you are cutting through the frontal horns and the temporal lobe of the brain. So let's see what the USG image translates into. So you are seeing 3 anechoic structure, 2 small anechoic structure here and here, and there is a midline anechoic structure. There is a parallel tram track kind of line, the interhemispheric fissure, which we already discussed. There is some kind of Y-shaped structure here, which we will see what is it. And this Y-shaped structure is partitioning this part and this part of the brain. So let's look at the labels. So as we discussed, the interhemispheric fissure, the parallel lines being the corpus callosum. Since we were cutting through the anterior horns of the lateral ventricle, obviously the frontal horns of the lateral ventricle we are seeing. And as we discussed, between the frontal horns of the lateral ventricle lies the cavum septum pellucidum. This Y-shaped structure, the sleeping Y-shaped structure, is the Sylvian fissure, which is kind of separating and the frontal lobe with the temporal lobe. So this is the temporal lobe aspect. So in the second plane, the most important thing is that we are getting the frontal horns of the lateral ventricle, cavum septum pellucidum, and the corpus callosum. Let's move to the third plane. So the third plane we would be cutting across is the foramen of Monro, which is also called the mid-ventricular plane. So when you cut through the mid-ventricular plane, you can yourself see that you are cutting across the lateral ventricle, the third ventricle, you are cutting across the temporal horn of the lateral ventricle itself, and you are cutting across the pons area also. So if you look at the anatomical image, here you can see what we are expecting to find is the lateral ventricles. As we talked that beneath the inferior part of the lateral ventricle in the anterior aspect is the caudate nucleus. So we are finding the caudate nucleus, and lies here is the third ventricle for the first time. So let's see what it looks like on the ultrasonography. So we have found the interhemispheric fissure from the first image itself. Then there is this parallel tram track line, which is the corpus callosum. Now we are finding the body of the lateral ventricle. As we discussed, we are cutting across the body of the lateral ventricle. The body of the lateral ventricle, here lies another thing, which is the third ventricle, just below the body of the lateral ventricle, as is in this image we are seeing. We are cutting across the third ventricle. Now, as we discussed that the lateral ventricle just in the inferior aspect towards the anterior side would be caudate nucleus, and just beside that would be thalamus. Okay. So in this third plane, the foramen of Monro plane, the major structures being seen are the body of the lateral ventricle, the corpus callosum, the third ventricle, the caudate nucleus, and the thalamus. So these things have to be noted. And obviously the Sylvian fissure, which we noted in the previous image, is also being seen. So another sonographic image of the same plane, where you can see very clearly here, even the foramen of Monro can be seen from the lateral ventricle. The foramen of Monro is leading into the third ventricle. And as we discussed, the caudate nucleus is getting noted here. And here lies the thalamus. And here lies the corpus callosum. So I think this is pretty clear. Now, moving backwards in the plane 4, that is posterior to the foramen of Monro. So in the previous image, we had covered the foramen of Monro. Now we are getting more posterior to the foramen of Monro. And for the first time, you can see that there is this hyperechoic black structure which is getting cut. So we are cutting the lateral ventricle, then this black hyperechoic structure, which is notified in this 2D image, and we are cutting across the cerebellum. So if we translate this into the USG image, we are getting what is the lateral ventricle, and in between you can see symmetrical specks of hyperechogenic material. So this is nothing but the start of the choroid plexus. So when you see this tiny symmetrical looking structure and you are in this particular plane, the posterior to the foramen of Monro plane, this is choroid plexus. And here you can see that there is a tree kind of appearance that is nothing but the cerebellum. So this is the part of cerebellum. This anterior aspect of the cerebellum, which is the tented part, since it is the tented one, this is the tentorium cerebelli. So let's look at the labels. So here we can see the lateral ventricle. As we mentioned, here is the choroid plexus. To the top of it is the corpus callosum, the body of lateral ventricle as always. Here the Y-shaped Sylvian fissure again is getting noted, and cerebellum and the tentorium cerebelli. Posterior to the cerebellum, there is a space called cisterna magna, which also can be appreciated here. Now let's move further posterior, and moving further posterior, we are cutting more posteriorly into the lateral ventricle. So after body of the lateral ventricle, as we discussed in our previous slides, the trigone of the lateral ventricle is getting cut, and more bulk of the choroid plexus is getting cut. So what we expect is lateral ventricle, and this thick echogenic material, which is often confused with bleeds, is the choroid plexus. So these are symmetrical structures, and looking at the location, the position, these are the choroid plexus, and in between you can see the corpus callosum. Now moving further posteriorly into the 6th plane and the last coronal plane is the occipital cortex. You are not cutting any ventricular area in this. You are not cutting any cerebellum. You are cutting the cortical area. So you are into the occipital cortex, and what you are seeing is the interhemispheric fissure again, the periventricular white matter where you can look for bleeds or cysts, parietal lobes, and the occipital lobes. As I talked that this is the occipital cortex plane. So this was the coronal plane. We covered 6 planes as discussed, and now we are moving into the sagittal planes. So sagittal planes, as we discussed, would be 1 in the midline, the mid-sagittal, 2 in the parasagittal region. The first parasagittal region would be cutting through the ventricle, the lateral ventricle. So it is the parasagittal ventricular plane, and the third plane is the parasagittal cortical plane, because it is not cutting the ventricle, rather it is cutting the cortex. So let's see what we get in these views. So first of all, as we already noted that the marker is facing towards the mid face of the baby or the forehead of the baby, and we have rotated the probe 90 degrees from the right orientation of the probe marker to the anterior orientation of the probe marker. So if we look at the midline section, the mid-sagittal section, if anatomically we need to revise, these are the things which we have already discussed. The corpus callosum sitting on the top, the cavum septum pellucidum, which we already covered, that this is a fluid-filled fetal structure, the cavum septum pellucidum. Then comes the lateral ventricle. The lateral ventricle goes into the aqueduct of Sylvius and opens into the 4th ventricle. Now the 4th ventricle is lying as a sandwich between the cerebellum and the pons. So the 4th ventricle lies in between the cerebellum and the pons. So you can identify these structures with this. So let's mimic this structure on as to what we see on the USG. So on the head ultrasound, when we do the mid-sagittal plane, what we can see is this structure, which is exactly this structure, the parallel structure looking like an arc, and this is the corpus callosum. Here you can see the fluid-filled structure, which is the cavum septum pellucidum, as we discussed, and from the posterior aspect, it is named as cavum Burgi. So this is the cavum system. This greenish structure as a whole is the ventricular system, as we discussed. So this is the third ventricle. This minor hyperechoic structure is the thalamus intermedia, where both the sides of the thalamus meet. So it may cast a shadow like this. Third ventricle leading to the aqueduct of Sylvius, and this is the fourth ventricle. So the fourth ventricle, as we discussed, is kind of sandwiched between the cerebellum, the cerebellar vermis, and the pons. Okay. So if we look at the labels, the third ventricle leading to the aqueduct of Sylvius, leading to the fourth ventricle, we have the cerebellum, the vermis of the cerebellum. And if we look at the fourth ventricle, to this side is the pons, as we discussed. Fourth ventricle, pons on one side, and the vermis of the cerebellum on the one side. Now, if you look clearly at this picture, this is also another midline sagittal plane taken from some other machine. So you can see, or carefully if you can inspect, there is a hyperechoic line going like this till the cerebellar shadow. So the cerebellar shadow is this one, and there is a hyperechoic line going like this. Okay. So if we kind of outline the hyperechoic line, so this is the hyperechoic line which is meeting the cerebellum, and this famously is sometimes known as the lady in dress sign. So once you are looking at doing a sagittal view, you have how do you know whether you have achieved the proper midline sagittal view? Is that you can get a lady in dress sign, and you, as we discussed, all the structures, other structures, corpus callosum, cavum, third ventricle, fourth ventricle, all these would be seen. So sometimes this terminology is used, that lady in dress sign is seen in a perfect midline sagittal view. Now looking at the next plane, the parasagittal ventricular plane. So as you cut on the ventricle, this grayish area, the C-shaped area with a tail, as we discussed, the lateral ventricle. So this is the frontal horn, the body, the occipital horn, and the temporal horn. Now a rugged area in between the body going to the temporal horn is the choroid plexus, which you would be seeing. And again we have discussed that slightly inferior towards the anterior aspect of the frontal horn of the lateral ventricle lies the caudate nucleus, and just posterior to it lies the thalamus. So let's look as to what it looks on the USG screen. So here again we have this structure which is going right through here and here. We have a hyperechoic thing which is lying from across the midway to the temporal horn aspect of this side. And if you look closely, there is a groove at this point. Okay. So let's see the labels. So this is nothing but the lateral ventricle, as we discussed, and the hyperechoic structure is the choroid plexus. Now looking at the other structures which are very important in this view is that we have the caudate nucleus, as we discussed, anteroinferiorly, and just posterior to it is the temporal lobe. So as the name itself suggests, caudothalamic groove. So it is one of the most important grooves of the structures in cranial ultrasound if you would be studying intraventricular hemorrhage. So the grade 1 hemorrhage starts from here, the caudothalamic groove. So caudate and thalamus, these two structures, there is a groove which is getting formed, and hence the name caudothalamic groove. So caudate nucleus, thalamus, caudothalamic groove, you are getting the lateral ventricle in which you are getting the choroid plexus. Another image where we can see a better lateral picture of the lateral ventricle, we can appreciate the posterior horn here, and we can appreciate the temporal horn here. Anterior horn, body, posterior horn, and the temporal horn of the lateral ventricle. Now going further across the plane third, which is the parasagittal plane of where we are cutting the cortex. So here when we are cutting the cortex, what we are seeing is this prominent point, which is the Sylvian fissure, and we are seeing the cortical portions of the brain, the parietal lobe, occipital lobe, temporal lobe, all these structures. So if we look at the USG, we will be finding this particular kind of fissural line, which is nothing but the Sylvian fissure. And this is the periventricular white matter. We often scan this. This is very important if we look at the PVL cases, and the Sylvian fissure, inferior to which is the temporal lobe, as we have discussed. So we have covered the standard windows, the 6 coronal planes, the 5 sagittal planes. I would take another 2 minutes just for touching upon the supplementary acoustic windows. So whatever information we gather from the standard window, we can supplement it with the three supplementary windows. The one is posterior fontanelle, where we are looking at the ventricle from a posterior aspect. And as you can see, we are looking at the ventricle from this aspect. So we are getting a good picture of the occipital horns because we are lying adjacent to the occipital horns of the lateral ventricle. So we can look at the occipital horns, the temporal horns, and the choroid plexus. And if any bleed is there in the occipital horns or the temporal horns, we can get a note of it. The other two sections, the temporal window and the mastoid window, these are also called the axial sections or the horizontal planes because we are cutting the brain into a superior and inferior half. Okay, so here the probe is kind of pointed ahead in front of the ear, and the probe would be pointing towards the anterior fontanelle. And here you can get a picture of the brain which is in the sleeping state. So you are getting this picture where you can kind of identify the lateral ventricles getting in terms going into the connection with third ventricle. Here you can also see fourth ventricle very nicely. And if you can appreciate, there is a butterfly shaped structure which is the cerebellum. As we all know, the fourth ventricle lies in adjacent to the cerebellum. So we are seeing all the ventricles. It's like the ventricles are sleeping and getting connected towards each other, and all the ventricles kind of are visible in this technique. In the mastoid window, we place the probe just posterior to the earlobe, and what we can see is the cerebellum in its full glory. So we can see cerebellar hemisphere, the vermis, the fourth ventricle, and the cisterna magna. So this would be an advanced kind of workshop where we would be talking about this further. So what we have accumulated in the last 30-40 minutes is that we have to know anatomy before jumping into the action with the probes and all the ultrasound machines. So once we covered the anatomy, it got better with time that you could understand the ultrasonography pictures. So always revise your anatomy, always go through the exact anatomical planes and what to expect in a USG image before jumping into the USG machine. Standard window, which is the anterior fontanelle, is mandatory in cranial ultrasound. So you cannot miss the anterior fontanelle window, which is most important to master. And if you have mastered that, half the job is done. We talked about 6 planes in the coronal section, 5 planes in the sagittal sections. You have to document these 11 planes for a standard window to complete. So don't rush through the planes. Always document the 6 and 5 planes, and you would be much better at understanding the brain structures. Supplementary windows also important, as we talked about that the posterior fossa structures and cerebellum can be is of very importance in the extreme preterms and all the newborns. So this we would be talking about later in some other CMEs. And never to forget that you don't kind of become the best sonographist in a day. So practice makes us better each day. We all are improving each day by practicing. So keep practicing. So that's my time. Thank you.
Thank you, Dr. Ankit. It was really great presentation, and very concisely and very appropriately you have shown the basic structures that we need to know as a neonatologist who has been doing the point of care ultrasounds. So in next 15 minutes, what I will do is I will show the live demo of these views, what Dr. Ankit has just shown. That is your 6 coronal and your 5 sagittal views. So where we keep the view, where we keep the probe, and what all structures we see. So what I will be doing, and this is for our support staff, also support people also, who is being managing the online this thing platform. So I will be logging in with my mobile, and then if you can spotlight that particular mobile, the device, the name will be Dr. Mohit Sani, or I think so. I will just log in. So please try to spotlight that device so that everybody can see that, and it can be recorded. That live session can be recorded. I will request to rename this new login device. Either you can put Mohit phone or something like that. I'm not able to rename it. This one.
What is the issue?
Alright. Please rename because both are Mohit Sani. My phone with which I am logged in. If you can just rename this. Yeah, I know. I'm going out of this, but I would like to request this support people to rename the phone device. I'm going for the live demo in the NICU. So everybody just and support people, please pin this device or spotlight this so that I can. This remains on the center of the screen. I will not be able to listen to any of your things. Only the chat if I will be able to see. So please put it in the chat if any issues while doing the demonstration. So good afternoon, everyone. So good afternoon, everyone. So what we will be doing in next 15 minutes, I will just show you the 6 coronal sections which Dr. Ankit has just told you and the 5 sagittal sections on the head ultrasound. Regarding the machine, Dr. Kamal has very well explained to you. So what we do is there are different panels in the screen in the different folders. So in that, first you need to do is from the heart folder where you are doing the cardiac echo, you have to shift and there are all presets. I have to shift to the head ultrasounds. So I've shifted to the head ultrasounds and the machine लॉक कहाँ करती है यार. So this is the machine. This is again my phase array probe. In newborns, you can very well do the head ultrasound with the phase array probes. This is your probe and this is a probe marker. So in head ultrasounds, you need to keep the baby either way. You need to keep the baby in supine, neck in the middle, And then after putting the gel, first we'll do the sagittal views. Sagittal views are being done through AF, anterior fontanelle. So here is the anterior fontanelle. So where we keep the probe, the probe pointer is to be directed towards the right side. If you imagine a clock in front of the baby's head, this is 6 o'clock, 12 o'clock, 9 o'clock, 3 o'clock. So you have to keep the probe marker towards 3 o'clock. Towards 3 o'clock here, towards the right side. We start from anterior, as Dr. Ankit has very well explained, from anterior, and then we go to posterior. From anterior, we go to posterior. So have 6 sections. How? First we'll go to anterior, like here. So when we say sweep, sweeping means this is the foot of the probe, this is the tail of the probe. The foot of the probe, so ultrasound waves are like this. So when the foot of the probe moves in the plane of the ultrasonic waves, it is sweeping or tilting. When it rotates perpendicular to that, it is rotation. And when it is right angle to the plane of the ultrasonic waves like this, it is angulation. Sweeping or tilting, rotation, angulation. Probe marker is towards the right side of the baby. And as on the horizontal. And here you will see this is your sectoral probe. So the sector-like thing will be seen. Probe orientation marker here is always on the right side of the screen. In head ultrasound, in cardiology, it will be on the left side of the screen. As I have chosen neonatal head, so that's why it is on the right side of the screen. The first section so these are the orbital ridges. First section, interhemispheric fissure, just frontal lobe, and these are the orbital ridges. We go sweep bit backwards, posteriorly, frontal lobe, interhemispheric fissure, and corpus callosum you have started seeing. We still go back a bit, posteriorly. You will start seeing corpus callosum. This is the third section, C3. This parallel line, this hyperechoic line is corpus callosum, cavum septum pellucidum, lateral horn of anterior ventricle, interhemispheric fissure. You still go backwards, what we call as 3-dot sign. So you start seeing this is the corpus choroid plexus, corpus callosum, and then the ventricle of the third roof of the third ventricle. And then is a trigon view, that is C5. These are the choroid plexus. And if we still go posterior, then these are the posterior lobes. So these are the 6 coronal sections. And the movement of the probe I will show you. I'm moving from C1, C2, C3, C4, C5, C6. Probe orientation marker, probe marker is on the right side. Start from anterior, C1, C2, C3, C4, C5, C6. So this is through the AF, anterior fontanelle. So C1 section is C1 section is where you see orbital ridges, interhemispheric fissure. C2, frontal horn, frontal lobe, interhemispheric fissure. C3, corpus callosum, cavum septum pellucidum, corpus callosum, lateral horn of the lateral ventricle, Go back, the third ventricle, 3-dot view, that is C4, trigon, that is choroid plexus C5, in the posterior. And this is a Sylvian fissure. This one is a Sylvian fissure. And when we talk about sagittal views, in sagittal we have mid sagittal, left parasagittal, right parasagittal, and left paraventricular, periventricular, right periventricular. So this motion is lateral. That for coronal, the movement was anterior to posterior. In sagittal, the movement of the probe is lateral. Probe marker is now pointing at 6 o'clock in front, like this. Okay, so this cutting the baby into two halves, like this. Ultrasonic waves. They are cutting the baby like this. So it is in front, like 6 o'clock. So when the mid-sagittal view is also known as lady in dress view. So it looks like a lady in dress view. Cavum septum pellucidum, corpus callosum, third ventricle, fourth ventricle here, third ventricle, and then you have cerebellum and midbrain. And then if we sweep lateral, either right or left, we have parasagittal. From mid-sagittal, this is mid-sagittal view. I am going to the left parasagittal. So this is your anterior horn of lateral ventricle, posterior horn here, inferior, and this is occipital horn. This is choroid plexus. This is caudate nucleus. This is thalamus. This is caudothalamic groove here. Caudate nucleus, thalamus, choroid plexus, posterior horn of lateral ventricle, inferior horn, and the anterior horn. This is parasagittal. And then if we move further lateral to this is periventricular. Sylvian fissure, frontal lobe, parietal, occipital, temporal. Temporal, occipital, parietal, frontal, and this is your Sylvian fissure. So these are mid-sagittal, that is lady in dress view, right lateral, that is right parasagittal, right periventricular, left parasagittal, left periventricular. So total 5 sections in sagittal, and the 6 sections C1, C2, C3, C4, and C5, C6, that is in coronal sections. In coronal section, the probe is to be kept in AF, pointer pointing towards 3 o'clock or right side. And then from anterior, it is being sweep or tilted posteriorly. So C1 section is, you will just see orbital ridges and frontal lobe and interhemispheric fissure. Go to C2, second section, you will see interhemispheric fissure and start seeing the corpus callosum. Third is, that is foramen of Monro view. So there you will see the lateral horn of the lateral ventricles, frontal horn, choroid plexus, corpus callosum, cavum septum pellucidum, and the third ventricle. C4, you will start seeing choroid plexus, anterior body part, and then roof of the third ventricle, 3-dot view. C5 is trigon view or choroid plexus view, and then posterior, like extreme posterior, that is C6, you will see the posterior lobe, that is coronal section. For sagittal, this probe marker comes at 6 o'clock, mid-sagittal, right parasagittal, left parasagittal, left periventricular, right parasagittal, and right periventricular. So these are the 5 sagittal sections and 6 coronal sections in the head ultrasound. I will just check the chatting. If there are any questions, I can demonstrate or answer. Okay. I will explain the gain. So gain button is basically okay. I will show the axial view also. So gain button is basically there are 2 ways of adjusting the gain. One is by auto gain. Just press and as you see automatically it has adjusted. Then I can increase or decrease. So if I increase the whole
Mohit, somebody
sector,
was
the whole
asking
sector's gain will be
Kishore
increased.
Kodathalamic
And if I
group.
decrease, the whole
I think you
sector's
must
gain
have
will
left.
decrease. It becomes more black. So it is basically a contrast between gray and black. Yeah, see the RI and all those things, we do it in the advanced CME. So we will be holding those sessions also, but over time. Today, we just want to touch away the basic things so that everybody gets updated regarding the basic things. Then we will go for the advance in the segmental small CMEs. Okay. So this gain I have explained. I will again explain the somebody asked for the axial. So the axial or sometimes temporal view, we keep the probe on the temporal fontanelle. This is a line, tragus and icanthus. There, the pointer is pointing at cutting at 45 degrees here. Come here. And this is your temporal fontanelle view. So you will see this is third ventricle, here will be fourth, and there is the cerebellar hemisphere. One is right, one is left, fourth ventricle, third ventricle. In this view, somebody asked where you will see circle of Willis. So temporal fontanelle view, you will see circle of Willis. Let me put the color and show you. Pass me the. So this is your circle of Willis. As we have not discussed IVH, so because we just want to discuss basic views, so we will be doing that when we'll do only CME on head ultrasound, or that is more of a, because it becomes very difficult to explain everything within this short time. So this is the 6 coronal sections, C1 to C6, and 5 sagittal sections. And in addition, I have just shown you the temporal fontanelle view, in which you are able to see the third and fourth ventricle with cerebellar hemispheres and circle of Willis. So I will be just going to my, I will log out from this phone and I will go to my main laptop, and then we will carry on our CME for the further lectures. Okay. I will again just show you in temporal view once again. Pass me here. This is third ventricle. Here will be the lateral ventricles. Third ventricle. Here will be the fourth ventricle, and these are cerebellar hemisphere, right and left. And this is the third ventricle. Let me zoom it. Lateral ventricles here, third ventricle, fourth ventricle. In here, you, when I put a color, you will see circle of Willis here. लॉग आउट कर दे, उसमें से स्वैप कर दे बेटा, इसको क्लीन कर दो ना बच्चे को। हाँ, इसको ऐसे रहने दो। डाल दे इसमें। फोन मेरे को दे देना, लॉग आउट कर दे, लीव कर दे। Hello everyone, I hope that clears. Yeah, there will be a lot of things like we have temporal view, like we keep the probe orientation marker, the line joining anthers and line at 45 degrees here. But see, all these special views and everything comes into advanced workshop when we do. So it will be best if we will discuss those special posterior fontanelle, temporal fontanelle, mastoid fontanelle. There are 3 other fontanelle, but the issue is if you want to cover everything, we cannot do it in the stipulated time. So that's why what we want was to just initiate the things, and then we can take on the CMEs on the separate different topics in small sections. And and this is what we complete in our 6 months courses that I just explained. So in 6 months courses, we in detail we complete head ultrasound, lung ultrasound, abdominal ultrasounds, even the central lines, pericardial depth, all this tip pointing, all these are in detail that we cover. So there because we have time there, almost 50 sessions to cover everything. So that's why it has been covered and demonstrated in very because if you have time, you can cover in detail with all these things. But we will be conducting small CMEs on separate issues. So now what we'll do is there is a break. No, yeah. So this is something I need to bring in everybody's notice. See, the CMEs is just for your knowledge updation. Okay. So yes, we do 1 to 4 weeks hands-on courses, but as per the PCPNDT Act, 1 to 4 week courses are not recognized. It has to be 6 months course by PCPNDT if you are in India. And this is just a CME for your knowledge gain, and we want people working in ICUs to gain this knowledge, and they help the add on with the clinical knowledge so that it becomes useful for them. So we are not training anyone to become a recognized certified radiologist or cardiologist. So only the certified radiologist and cardiologist can give the reports. So everybody should be aware of this. Otherwise, if it become medical legal issues, it will hurt everyone. So we should be very careful about all this. So till now, no MD Gynec, MD Radiology, Cardiology Fellow, DM, DNB Cardiology, FNB Cardiology, and now DM Neonatology are recognized to give the reports and give the findings. Recently, DM neonatology and DNB neonatology has been recognized, but still you will have to get trained somewhere, and not MD medicine and MD pediatrics, no. Till now, no. So what we will do is, now the cardiac sessions will start. Cardiac session will start from 3 p.m. Yes, case sheet findings, you can very well document it. Yes. In case sheet finding clinical notes, you can document everything and you can take action on that. So that is as for the treatment of the babies. So now it's 2:33. We will restart the cardiac session at 3 p.m. as per the schedule. From 2:30 to 3 o'clock, there is a break. Still, it has not been recognized the DNB Pediatric Critical Care Fellow, but DNB Neonatology and DM Neonatology is being cleared by the this is as per my knowledge till now. So still, after 6 months course, still you will get the registration in PCP and DT of the machine, but you are still a neonatologist or a pediatrician with the 6 months course. So you are not a recognized cardiologist. If somebody is there in your center or in your city with pediatric cardiology fellowship, then it may happen that they may ask, why did you refer to the pediatric cardiologist? But after 6 months, you will be cleared to register your name in PCP and DT. You can use the machine, start using it on the babies. You can get your name registered. You can buy the machine in India, not outside India. In India, this is something which is minimal need. If you want to have a machine in your unit, you want to use it for doing a head ultrasound, echoes or whatever. Yeah, the course price I will be post. If you can just send me the email on, if everybody can send an email on nfecho2505@gmail.com. I will send you the full details. nfecho2505@gmail.com. I will send the complete. Yes, so the thing is, as per PCP and DT, this has to be physical. So in our certificate, we did not mention online. So it is basically that it will be shown that you have done a full 6 months course. And physical hands-on is at 2 places, one at Surat and other is at Mumbai with Dr. Kiran, and one at Surat with me. Yes, recording will be given, link will be shared next week, and it will remain active for 4 weeks. I will try to give the e-certificates and I will send by the email. There are few emails which bounce back also in the list, but I will try to do that. And not with WhatsApp, because now WhatsApp, they are blocking. If you do mass messages or you try to create the group, they're blocking. My last 3 days, because I was supposed to add on people in the groups and this thing, it blocked. It blocked my WhatsApp got blocked by 5 times and restarted. So we will meet at 3 p.m. again with the cardiac echo sessions at 3 p.m. So it is a break for around 24 minutes. 24 minutes break. We'll see you in next 20-25 minutes. So, good evening, everyone. Welcome back to the session of the CME on neonatal POCUS and functional echoes. So, this is our CME program. Just for the heads up for everyone, we have finished up with the basic principle of ultrasonography, machine settings, and neurology live demo, and then we finished with the basic normal views of the head ultrasound demo. So now we will be starting with the normal basic views of heart, what we do in functional echo by myself, and then we will do the live demo on the babies regarding the basic views of the heart. Subcostal views will be demonstrated by Dr. Kiran More, and apical four-chamber and other views. What we will see in this next session will be live. I will do the live demo, and then after that we will go for basic views of the lung ultrasound, and then we'll go for the live demo of the lung ultrasound. So again, before starting, I just want to press that this is just a initiative taken to just give you the taste of point of care ultrasound or functional echo. So if somebody is interested in detail, so that this knowledge always helps us in taking care of the babies in NICU, so then you can do the 6 months online or online plus physical hands-on 15 days hybrid courses that we conduct by NfECHO Academy and FOCUSin by myself, Dr. Kiran More, and our team. If you are interested, you can WhatsApp us on this number 777-8989-842. This is a country code, or you can email us on nfecho2505@gmail.com. We do have our YouTube channel, Instagram page, and the Facebook page. You can follow that, subscribe to the YouTube channel. On YouTube channel, there are small videos have been uploaded regarding how to take various views, and that lecture and live demo, everything is there. And on very small topics, as there were questions regarding IVH, hydrocephalus, and all those small videos are uploaded on the our YouTube channel. And as I've told in the starting of this CME, that this thing, our courses are certified courses, 6 months courses. The academy is registered to Government of India, and you get 5 books, almost 500 published papers, and free subscription to the app. And almost 26 international candidates have come for the physical training. Most of them, they are come for 2 weeks. In candidates from various parts of the world, Indonesia predominantly, Dubai, Bangladesh, few from USA, but mostly Indonesia and Qatar, like our Arabic countries and Southeast Asia. And those, all our faculty is basically what they have been gone through these courses, and then they have become the faculty in our workshop. And most of the lectures which have been taken by our people who have done the courses, and they have done well in the field, and they have been leading it. So I will start with the views, echo views. I hope everybody is able to see the screen. If somebody can just in the chat send me thumbs up, it means okay, fine. Thank you. So we will go to the views. Basic things regarding the basic principles regarding the optimization of the image. See, the most important optimization of image value is being seen, and it is important when we discuss echo, functional echo, because it is the toughest part in point of care ultrasound, because all other organs like brain, lung, other parts, they are static organs. Lung is dynamic organ, it's moving. So that's why there are various views, multiple sweeps or tilt. I showed you in the live demo what we call sweep, what we call as a tilt. When we call that the probe is to be swept, sweeping movement, angulation is there, or rotation is there. So all those things we need to keep in mind, and that becomes basic principles become very important in while doing the echo views of the heart ultrasound. So that's why we should be well versed with that. So let's start. Like, you have been attending this and even though we have not been getting interactive, but in most of our sessions, especially in our courses, we are very interactive with all the attendees, just to make them to learn and learn in depth. So this is a tale of two students who they were waiting to give their oral viva test. The first student's turn comes and he goes inside. The external examiner was sitting inside. This must be very well felt by people who have been trained in India and they have gone for their exams in India. They are very strict and they are like that. So suppose you are traveling by train. This is what the external asks the student. And by noon time, it gets hot. What will you do? The student tells, the first student which has gone in, I will open the window. The external again asks, great. Now suppose that the area of the window is 1.5 square meter and the volume of the compartment is 12 meter cube. The train is traveling at 80 kilometers per hour in western direction and the speed of the wind is 5 meters from the south. Then how much time will it take for the compartment to get cold? For this, the student could not answer. So he marked fail and he comes out. After coming out, he tells the question to the second student who was waiting for his turn. Now the second student goes in for his viva and viva starts. The external asks, suppose you are traveling by a train and it gets hot by afternoon. What will you do? He told, I will remove my coat. The external again asked, if still it is hot, then what? So he told, I will remove my shirt. So external got really angry because he was not getting the answers which he wanted. So if still it is hot, then what will you do? He told, I will remove my banyan. Banyan is something, what we wear under shirt. In India, everybody knows that, but outside, this is for people who are from the other countries. So it is something West, what we call as the West. So external got fuming. So he there, if you die due to heat, what you will do? So student told, if I die due to heat, I will not open the window. So you have to improvise and learn. So that is what is the message by these slides. See, we optimize the ventilation. We optimize the ventilation by graphics. Okay. Similarly, we optimize the hemodynamic treatment in the newborns by functional echo. So this is what is the main role of echo. And as everybody was asking in previously also, that do we give reports after doing this CME? It is no, because after doing this CME, it is just an initiation. So it is not that you have become a registered cardiologist. So that's why you cannot write the reports unless you are a trained certified cardiologist or a radiologist. So whenever as a neonatologist you are doing an echo and you find something wrong with the structure, it is always good to involve the pediatric cardiologists. This is one, I would say, a disclaimer that I would like to bring before going to the basic views of the heart. So when we talk about the basic views, so there are different windows, what we call of windows on the baby's chest and even on adults. So from where these windows have come in? So the windows have come in, basically these are the areas where we keep our probe. So the probe we use in echo. Can anybody write in the chat box that which probe we use while doing an echo? Phase array, yes, very nice. So it's a phase array probe, that is sectoral probe. Okay, good. Why? Because its footprint is small So, and especially newborns and in even adults, the windows for the cardiac views are very small because they are restricted and hampered by the presence of ribs, that is bones. So that's why. And from where, is there any science behind these windows? It is no. With experience, when the people started doing an echo, with an experience, so as per the consensus, they have come out that this area is the perfect area to see this particular view of the heart. So that's how they have segregated and they have formed the windows, that there are the windows that are available for this particular view of the heart. So then that's why we have apical windows, subcostal windows, parasternal windows, there is low parasternal and high parasternal windows. That's how we have distributed the various views on the baby's chest. Why I'm showing this slide is, it may happen that I am doing the echo on this machine and I'm showing you this, but you have this machine. So you should not be worried, because the basic functions of all the buttons remain the same. The nomenclature may be different. Okay, the shape may be different. The arrangement of the buttons may be different. But what Dr. Kamal has shown in the morning, the basic functioning of all the buttons will remain the same. Before going to the windows, we should understand the basic screen of an echo. So this is, as most of you have written, phase array probe, that is sectoral probe. So this is how the sectoral probe window will look like. So this is a sector and this is your heart. So when we say that this image is optimized, the first thing is the depth. So with that, when you put the probe, what you will see is, you will see the heart is this much in the sector. Okay. So then you decrease the depth and make it big. So now you see in this, the heart is this much. So when we say it is optimized depth, when the organ for whom we are doing the study or whom we are doing the ultrasound should fill at least 60 to 70% of the area in the sector, we call the depth is optimized. So that is your regarding the depth. Okay. The next thing is gain. So gain we have discussed. You can increase and decrease the gain with the gain button to get a optimized contrast between black and gray. 60%. And then this is your probe orientation marker. It corresponds with the marker, the probe marker, the marker on the probe that I showed you when I did the live demonstration of the head ultrasound. Okay. In cardiology, it always remains on the left side of the screen. In radiology, like we did the head ultrasound, it always remains on the right side of the screen. So as you can see, it is on the left side of the screen. In cardiology, it is always on the left. You can just move it up or down. So you can move up and down depending on which view you are going to take. This is your scale range. So you should be adjusting the scale for when you are doing the Dopplers of one particular area. Like if you are doing the Dopplers of aorta or pulmonary artery, so those are the arterial flows. So your scale should be adjusted around 0.7 to 0.8 meters per second, because that is high velocity structures. But if you are doing the Dopplers of the pulmonary veins, they are low velocity structures. The flow in that will be low velocity. So then if you will keep the range high, you will not be able to detect the flow in the pulmonary veins. You will have to bring down the scale to 0.35 meters per second. Okay. So this is your scale range. This is your probe orientation marker. And this is the ECG. Ideally, all the echo studies has to be accompanied by an ECG. But for clinical purposes, most of us, we don't do it, but ideally it has to be done. So that is your echo, basic echo screen. And this is your color window, and this has been put on. Can anybody tell what is this chamber number? I will just put a number. If you can tell, number 1 is which chamber and number 2 is which chamber. If you can put it in the chat. Number 1 chamber, number 2 chamber. RA, yes. It's RA, RV. Great. So then which is this valve? The valve between 1 and 2? Yeah, so that is tricuspid. So you're while putting color, you are seeing the blood flow through the tricuspid valve. Great. Nice. Now I told you this is the probe marker and this corresponds with the probe orientation marker. Okay, now suppose this is your probe here. This is your probe. Okay, now this is your probe marker. This is left, this is right, and your probe marker is pointing towards left shoulder. That is at 2 to 3 o'clock position. Okay, so can anybody tell what is chamber 1, what is chamber 2? LA, LV, yes, LA and LV. Great. This is LA, this is LV. Now suppose your probe, what you have done is you have rotated the probe to exact 180 degree. Probe marker which was here is now here. This is your probe marker. This is your right, this is your left. This probe orientation marker remains there. The only thing is you have rotated the probe exactly to 180 degree and your probe marker is now pointing towards your right shoulder or 9 o'clock. So now anybody can write what is chamber 1 and chamber 2? No. It's RARB. Because you have rotated the probe. The orientation, the probe marker which was on the left side, 2 to 3 o'clock, is now pointing towards the right side. This thing does not change, it remains there, but this corresponds, so it is on the right side. So the chambers towards this probe orientation marker will be of the same side where this probe orientation marker is pointing. Previously it was pointing towards the left side, that's why it was LALB. But now after rotation it is pointing towards the right side, right shoulder, that's why the chambers on towards this probe orientation marker is RARB. So that's how it corresponds with each other. So that is the importance of probe marker and probe orientation marker. I hope you understand. This has been explained to you by Dr. Kiran and Dr. Kamal towards and away. So now we'll discuss the various windows on the baby's chest. One is apical window at the apex at the 4th or 5th intercostal space. But the thing is, I would like to bring up one thing. In adult, the heart is more straight, or pediatric patients like this. So the apex is like the heart apex is pointing here. But in newborns, the heart is more slanting. It's more slanting. Okay, so that's why whenever we do the apical views, is always good practice to start from the lateral and downwards. So this is the apical window. So apical window, where to keep, this is where you keep the probe for the apical views. Then there are parasternal views, parasternal windows. Parasternal is divided into two, low parasternal, high parasternal. So this is your nipple line. So this is your lower 1/3 of the sternum, and this is your upper 2/3 of the sternum. So upper 2/3 of the sternum, that is above the nipple line, is high parasternal views. Lower 1/3 or at the nipple line is low parasternal. So the parasternal is divided in high parasternal and low parasternal. Low parasternal is further divided into two, parasternal long axis and parasternal short axis. So you have apical window, the apical window number 1. Then you have parasternal windows. Parasternal windows are divided into low parasternal, high parasternal. Then comes the The suprasternal notch or suprasternal window is also, it comes in the high parasternal windows. And then the third thing is subcostal windows, that is below the Z fistula. In adult and pediatric, they always start with the subcostal windows because that is what we need to start, because in newborns also we need to start with the subcostal windows because we have to determine the situs first. But the thing what happens in newborns is the newborn, if they are not on the ventilator or sedated, subcostal windows, when we try to put the probe in the subcostal window, it irritates them and the baby, they start crying and become very irritable. So that's why we avoid subcostal windows to start with in the newborns, especially if they are not on ventilator. So I personally, I always start with the apical windows, go for low parasternal, then high parasternal, and then go for subcostal. Whichever window you start with, the most important thing is you need to complete the whole sequence. You should not miss any sequence. That is very important. So now in most of my presentation, in the rest of the presentation, I would request everyone to first concentrate on this part of the screen where you will see the video where we keep the probe. Then you concentrate on this part of the screen. There will be a video of what you are seeing. And then on this part of the screen where you will see the fixed image which has been labeled. So one is apical, then we have parasternal, low parasternal, high parasternal, suprasternal is a part of high parasternal, and then subcostal windows. So we will do accordingly. It is always a good practice to imagine a clock in front of the baby. This is 12 o'clock, 6 o'clock, 3 o'clock is left side, and right side is 9 o'clock, left and right. 12 o'clock, 6 o'clock, 3 o'clock, left side, 9 o'clock, right side. So we, in the rest of the presentation, I will be talking about the probe marker as per the clock. This everything you have covered. So basic views, first we do the 2D views. So this is how your 2D views they look like. Okay, gray and black. Dopplers, there are of three types: Doppler, color Dopplers, pulse wave Doppler, and continuous Doppler. That has been covered by Dr. Kamal in the morning and Dr. Kiran. And then the third modality is your M mode, which is a motion mode that cuts the heart, and we do the measurements and the contractility in that mode. So for the views, the first and foremost, what I told you that I will discuss from apical 4 and 5 chamber in 2D. It gives you, it is good to know the structures that 4 chambers are there or not, and then rest of the things we can assess by eyeballing and all. So now in this, you see where we keep the probe just below the nipple at the apex. It is always good practice to start from downwards and lateral, and the pointer is pointing in 2 to 3 o'clock position, that is towards the left shoulder. And then the orientation of this probe orientation marker comes. In adults, they keep this marker up here. They always keep this marker up here. So there, they always see the heart inverted like this. But in neonatology, we always keep the marker for apical 4 chamber view here downwards, so that we always assess the heart upright. So this is anatomically corrected heart. So this is anatomically corrected heart. So that's why for apical 4 and 5 chamber view, we keep the probe orientation marker down here. So this is your probe orientation marker down here. So this is your pointer pointing at 2 to 3 o'clock position, that is toward the left shoulder. So this is your LA, LV, RA, RV, mitral valve, tricuspid valve, interatrial septum, interventricular septum. This is the descending aorta, because aorta wraps around and goes down. So when you cut the heart upside down, it is right angle to this plane. So that's why it is cross-sectional. And you see 1, 2, and 3 pulmonary veins: LA, LV, RA, RV, descending aorta, and 3 pulmonary veins entering into LA. So this is your apical 4 chamber view. So then what you do, you rotate the probe clockwise. From 2 o'clock, it becomes 3 o'clock, and you sweep. I showed you what is sweep. So this is the foot of the probe. This is a tail. So when we say sweep or tilt, it is always with respect to the foot of the probe. So the foot of the probe moves anteriorly or upwards like this, anteriorly. So when it moves anteriorly, a fifth chamber opens up, what we call as aorta. So this is your aorta and this is your aortic valve. So this is LA, LV, RA, RV, interventricular septum, and this is your aorta, that is apical 5-chamber view. Okay. This is how the heart, this is the probe, this is the ultrasonic waves passing through the heart. This is how it will cut the heart and it brings the heart in front of you. This is a apical 4-chamber view, and this is the aorta which is being cut cross-sectionally. So then we put the color Dopplers. So we are doing the Dopplers for which valve? Can you write in the chat box? Yeah, so it is tricuspid valve. Very nice. So we are doing the Dopplers for the tricuspid valve. So the blood flowing from RA to RV is what color? What? Here is your probe. This is your probe. So blood. So this is your probe here. The ultrasonic waves are like this. So the blood coming from RA to RV is which color? Red, because it is moving towards the probe. Very nice. And the TR jet will be blue. It will be moving away from the probe. I'm doing the Dopplers for mitral valve. Blood flowing from LA-LB is red. MR is blue color. And this is apical 5-chamber. So now what I did from apical 5-chamber, I still sweep the probe more anterior. So anteriorly, what we sometimes it calls it, this is basically the pulmonary artery. The aorta which is right angle to it is gone, and perpendicular to it the pulmonary artery came up. So this is sometimes you also call it 6-chamber view. The aorta is gone, and more anteriorly when we sweep the probe, you start seeing the pulmonary artery. It is the pulmonary artery right angle to aorta. This you can get from this. This is a apical 4-chamber view, LA, LB, RA, RB. Anterior to this LB chamber is your aorta here. See, this is your aorta. And anterior to aorta is your pulmonary artery, and that is at right angle to the aorta. So that rules out one. When you sweep from 5-chamber, you start seeing pulmonary artery and the aorta is gone. So that sweep is from 5-chamber to 6-chamber. If you don't see both the vessels in the same view, it rules out one, congenital heart disease. Can you write? Blue is away from the probe. Yeah, no, yeah. So it rules out your TGA. Very nice. Transposition of great arteries. Red means towards the probe, blue means away from the probe. Okay, so that was regarding apical 4-chamber, 5-chamber, and 6-chamber views. So in apical window, we have two sweeps. We start with apical 4-chamber. We sweep anteriorly, that is upwards. We start seeing apical 5-chamber, and from there, if we sweep anteriorly, we start seeing apical 6-chamber or pulmonary artery. Now we come down to parasternal views. As I told you, parasternal views we divide into two: low parasternal and high parasternal. So we have parasternal views. Parasternal views, what we do is we divide the parasternal views into two. We divide it in low parasternal and high parasternal. Okay, so we have parasternal views, low parasternal, high parasternal. In low parasternal, we further divide into two. So in low parasternal, we have parasternal long axis, that is Black's view, and we have parasternal short axis, that is And we have parasternal long axis and parasternal short axis. Parasternal short axis. Okay. And in high parasternal views, we have further views, many views, but we will discuss only 4. I will discuss that. So what we have parasternal views. Parasternal views are divided into 2: low parasternal and high parasternal. Low parasternal are further divided in parasternal long axis and parasternal short axis. So this is how we divide our parasternal views. So first we will discuss parasternal long axis, in which the heart is being cut longitudinally. See here. Now the probe is being kept at the nipple line and the pointer is pointing at 11 o'clock position, that is towards the right shoulder. And now you can see in apical 4 chamber, 5 chamber, and 6 chamber, this probe orientation marker was here, but now it has gone up. So for rest of the views, it will be here. Only in apical 4 chamber and 5 chamber views, we have kept the probe orientation marker here. So it has cut the heart longitudinally. So the most anterior part is RV, right ventricle wall, RV cavity, interventricular septum, LV cavity, aorta. These are the aortic valve. This is mitral valve and this is LA. Mitral valve, aortic valve, LA, LV, interventricular septum, anterior wall of RV and RV chamber. See, the heart is being kept in the cage like this. The probe is here, pointer is pointing at 11 o'clock. These yellow are the ultrasonic waves which are going in cutting the heart. And this is aorta, LV, LA, mitral valve, RV. Okay. So this is how your parasternal long axis looks like this. The heart is being cut longitudinally and is brought in front of you. So I'm doing the color Dopplers. I'm doing the color Dopplers of which structure? Can anybody write in the chat box the structure for which I'm doing the color Dopplers? It's interventricular septum. Yes, I'm doing the color Doppler for interventricular septum. So this is your IVS, interventricular septum here. This is your interventricular septum. I'm doing the Dopplers for interventricular septum to see if there is any VSD or ventricoseptal defect or not. So now the next thing is, after this, what we do is we sweep the probe up towards the head. So what happens? The aorta which was here like this is gone, and instead of that, so here was the aorta. Now the aorta is gone, and instead of that, you have a vessel coming from upside down. So this is your pulmonary artery, and this was your aorta. So now you cannot see both the vessels in the same frame. So this is your pulmonary artery sweep or RV outflow sweep. So that again rules out your TGA. So I'm doing the color Dopplers for pulmonary. So this is your MPA, RPA, LPA. MPA, RPA, LPA. MPA, RPA, LPA. So this is a pulmonary artery. And now I sweep the probe downwards, foot of the probe downwards towards the foot. You will start seeing the tricuspid valve sweep. So this is the tricuspid, or also known as RV inflow sweep. So you have two sweeps. Sweep up towards the head is pulmonary artery sweep. Sweep down towards the foot is tricuspid valve sweep. So that is your parasternal long axis view. And then now we cut the heart in short axis. From 11 o'clock, it rotates and rotated towards and pointing towards the left shoulder. left shoulder now. From 1 o'clock, from 11 o'clock, it is now gone to 1 o'clock. From 11 o'clock, it is now rotated towards 1 o'clock at right angle. So you cut the heart at the base in cross section. So at the base from where the aorta starts, this is what you see, aorta in cross section, and it is known as Mercedes-Benz view. So this is aorta in cross section, and then you have 3 spokes of aortic valve. So it looks like a Mercedes-Benz sign. So that's why it is known as Mercedes-Benz view. So this is your aorta in cross section. These are the aortic valves. This is your pulmonary artery. This is right ventricle. This is your tricuspid valve. This is your RA. This is interatrial septum, and this is your LA. So this is your Mercedes-Benz view. So now what we'll do, we will sweep the foot of the probe towards the apex of the heart, towards the apex. So this is the base, and here will be the apex. So we'll move the probe from the base towards the apex. We will sweep. So if you imagine yourself to be a RBC, so if you travel from the base of the heart towards the apex, so when you enter the LV, the first structure you will encounter is mitral valve. So this is how it happens. It is cutting the heart at the base from where the aorta has started. So you see this Mercedes-Benz sign that we have already discussed. And then from base, from where this aorta has been starting, the base, we are sweeping the probe towards the apex. So while doing that, the next structure we will encounter when we will sweep down towards the apex is your mitral valve. So that is what we call as fish mouth view. So this is your RV cavity, interventricular septum, and this is your LV cavity, and this is your mitral valve. So this is fish mouth view. And when we sweep further down towards the apex, the next structure we will encounter is papillary muscles. So this is your LV, these are papillary muscles, this is LV cavity, and this is the RV cavity, and this is interventricular septum. And as you notice, the probe orientation marker is up here. And then we move further down towards the apex. Then we see that which is the apex forming chamber. Here you can see this LV will be gone, and your apex is formed by this LV. So in most of the cases, your apex is formed by LV only if it is hypoplastic left heart, or there is some obstructive lesions of the right outflow tract where the RV is very big and dilated and it wraps around the LV. Then RV is your apex forming chamber. Otherwise, LV is your apex forming chamber always. And now in this, we are again doing the Dopplers of the interventricular septum. So what we have done till now, we have discussed apical 4-chamber, 5-chamber, and 6-chamber view. Then we discussed the parasternal views. In parasternal views, we discussed that it is divided into low parasternal and high parasternal. In low parasternal, we have further 2 divisions, that is parasternal long axis and parasternal short axis. And now we will come to high parasternal view. High parasternal is nipple line and above, that is upper 2/3 of the sternum. Most of the views are at the upper 1/3 of the sternum, that is just below the clavicle. So the views we will discuss today, one is ductal view, pulmonary artery view, pulmonary vein view, and aortic arch view. These are the 4 views we will discuss in high parasternal views. So first we'll see, because in neonatology, this is very commonly sought after view, that is a ductal view, in which we see the PDA. So it is basically nothing but a modified short axis view, in which the probe is being kept in the left of the sternum, left parasternal area. Why we avoid left parasternal area? That is left subclavicular, left parasternal or left subclavicular window. Pointer is pointing at 12 to 1 o'clock position. Okay, so that is how we do it. I will just show you the video for that. Yeah, the probe is being kept in the left subclavicular area, that is upper 1/3 of the sternum of the left side, and pointer is pointing at 12 to 1 o'clock position. So this is what you will see. as you know, the duct is basically arise from, this is your descending aorta. From descending aorta towards, this is your pulmonary artery. So the PDA is a basically structure which starts from descending aorta and goes up and enters into pulmonary artery. So this is how the ductal view has been seen. So in this, you need to have at least two structures, pulmonary artery and descending aorta. If there is a PDA, suppose there is a PDA and here is your probe. If the PDA shunt is left to right, what will be the color? Can you write in the chat box? Anyone? Yes. If it is left to right, it is towards the probe, it is red. If it is right to left, it is away from the probe, it will be blue. Okay. So any defect in any view, if it is shunting left to right, it will be red, and shunting right to left will be blue. That is a kind of dictum. So you can, without seeing that where is the direction, what is that, you can just remember VSD, ASD, PDA, any view shunting left to right is red, shunting right to left is blue. So this is your ductal view. Upper 1/3 of the sternum on the left side, the left subclavicular area, pointer pointing at 12 to 1 o'clock position. So this is your pulmonary artery, aorta. Both are blue. And if you have a PDA like this, shunting left to right, it will be red. As you saw, Dr. Kamal was showing in the morning on the live demo, the duct was there, which was shunting, basically bidirectional, but predominantly it was left to right. So now we discuss the arch view. See, the arch view is basically typically the suprasternal view just on the suprasternal notch. But in newborns, what happens? The neck is very small, very short. So especially babies on CPAP and ventilator, it is very difficult to put the probe in the suprasternal notch area, especially in the preterm babies. So we can do the same arch view from the right subclavicular area. Just on the right side of the sternum, pointer pointing at 12 to 1 o'clock position. This is your probe marker and this is your arch. This is your ascending aorta. This is ascending part of the aorta. This is the transverse part. You can see three branches, 1, 2, and 3. And this is your descending aorta. So the whole thing is the arch is like this. So this is your aortic arch view. And this thing is your RPA. Because aorta and arch, they are right angle to each other, aorta and pulmonary artery. So pulmonary artery, when it divides, so one thing passes under the arch of aorta. So when the arch is being cut longitudinally, the cross section will be of pulmonary artery. So that's why this is your RPA, ascending aorta, transverse aorta, and descending aorta. It's the color flow. The next thing is pulmonary artery view and pulmonary vein view. So this again, the probe marker is here. I told you for the rest of the views, we will keep the marker here. And the probe is being kept on the left, again on the left subclavicular area, left side of the sternum. But now the probe marker, instead of 12 to 1 o'clock position, is at 3 o'clock position, is at 3 o'clock. So you will see aorta in cross section, and this is pulmonary artery, the MPA, RPA, and LPA. MPA, MPA, RPA, LPA. And this is aorta is in cross section on the right side of the pulmonary artery. And this small one here is the SVC. So the SVC, most right, then is aorta, and then is pulmonary artery. So these are the three vessels. This is your pulmonary artery view. So you keep the probe here and this view downwards, that is posteriorly. When you do that, in the colors of this. So when you do keep the probe there, sweep it further down posteriorly, you start seeing the LA, which is posterior to pulmonary artery, and then you see the pulmonary veins entering into this LA. So this is all when you put a color. Now for this, you are trying to see the flow in the pulmonary veins. Be careful regarding the color scale. Previously in aorta it was 0.7 to 0.8 meters per second. Now you can see it is 0.36 meters per second. Then you start seeing the flow in the pulmonary artery. You can see this pulmonary vein flow. This is also known as the crab view. Crab view. This is pulmonary vein flow, and this is what you see in the lower pulmonary veins, and then blue is from the upper. So you have 4 pulmonary veins known as crab view or pulmonary vein view. So that is regarding the high parasternal views. So high parasternal views, 4 we have discussed. We have discussed pulmonary artery view, pulmonary vein view, ductal view, and the aortic arch view. Now in the end, we will come down to the subcostal views. Subcostal views, there are two types of subcostal views. So one is longitudinal and the other is cross-sectional. For longitudinal, we keep the probe pointer at 12 o'clock. Cross-sectional, we keep the probe pointer at 3 o'clock. So here you see we are keeping the probe pointer at 3 o'clock, just below the G sternum. You can keep this probe marker up here, but I always again bring it down so that the RA is closer to the probe. So this is your RA, LA. So this is the atrial view. RA, LA, and this is the intraatrial septum. So this is your subcostal, cross-sectional or atrial view. We sweep it. Now you can see I'm trying to do the color Dopplers of intraatrial septum. Not able to see any flow across this septum. Why? Because you see the velocity range is 0.85. Atrial flow is a low velocity flow. So what we have to do is we have to bring down this scale down to see the flow across the intraatrial septum. So this is basically a subcostal this thing. This Dr. Kiran will be showing you for the situs. I will just directly go to the. So when you sweep this probe from the atrial septum, atrial view, sweep upwards anteriorly, you start seeing the SVC entering into RA. So what I am doing is I am doing the Dopplers of SVC. This red jet is the SVC flow coming into RA. And then you have a longitudinal views. Now the probe marker is at 12 o'clock. Instead of 3 o'clock, it is at 12 o'clock. Here you see this probe marker is up here. So this is IVC. IVC, hepatic vein, and IVC is entering into your RA. IVC into RA, and this is hepatic vein. Pointer pointing at 12 o'clock. Just below the xiphosternum, towards the right side, it will be IVC. Towards the left side, it will be aorta. This is your IVC passing through the liver, entering into RA. How it looks like. I just showed you. And when you sweep the probe towards the left side, you start seeing spine and tortuous vessel. Above the spine, with 2 outflow tract like this, branches. So this is your abdominal aorta with celiac and SMA trunk. So that is your subcostal views. So these are your various apical 4-chamber, 5-chamber, long parasternal long axis, parasternal short axis, high parasternal views in which that include ductal view, arch view, and then subcostal views. These are the various parameters we do in these views for assessment of various pathologies. Most common is PDA, shock, and PPHA. So this is how we do, and these are again in the high advanced echo workshops. We discuss all these things, all the parameters, because before that we need to be well versed with our normal views. So in the end, I would finish with that whatever we do, we have to do it very carefully. Until unless we are sure what we are doing, we should not be proceeding with that. So if you are interested, you can just WhatsApp us or this thing, email us for any courses. If you are interested in 6 months courses, so these are the books which you always get, and you can even buy also the soft copy of these. For this inquiry, you can just WhatsApp on this number. Thank you very much. I will stop my presentation here. We have to go for demo also. Subcostal views will be shown to you by Dr. Kiran. I've overshooted by 5 minutes. Tripod sign in VDA is in the ductal view only. Okay, I should have stopped my video. Got it. So bidirectional is red and blue. Yeah. I'm really sorry that this video was obstructed. You are right. It must have obstructed. But while presenting, I did not see your chat message. The tripod side is in the ductal view only. Okay, Dr. Kiran.
Okay, thank you. Can you confirm my voice is not shaking and I'm still audible, and you can see my slides as well.
Yeah.
So I'm actually I'm traveling overseas, so I've recorded the videos to demonstrate live. I'm not next to the bedside, but Dr. Mohit will be going to the unit and then he'll show demonstrate if there are any concerns. Okay, so Dr. Mohit, I'll start with the subcostal view, then you can set it up. The other views you can take on from there. Okay.
Yeah, we will do that. Yeah, sure.
Okay, so I hope everyone can see my slides.
Yes.
Perfect. So after the excellent lecture from Dr. Mohit, I'll continue with only focusing subcostal view demonstration, just some fine tuning into it, how you acquire those views, and then other views Dr. Mohit will take on. So important in subcostal views. Whenever you begin an echo, actually, when we say structure sequential scanning, we always start with subcostal view. But in practical life, a lot of time we avoid subcostal views because babies get upset when you start scanning on the abdomen, especially after the feeds. So we do a lot of time 4-chamber and parietal long axis and short axis first, and then come to the subcostal view. But in a proper echo, I think always better to do the subcostal view because it helps to rule out common structural heart disease. It ascertains there's a situs solitus. It tells you about the connections of the heart, if they're okay, aorta, IVC, the PFO, and the outflow track, and some SVC flow. And also it's a good view for asserting the central line or UVC PIC line positions, and also sometimes you can pick up some plots from it. So this is again Dr. Mohit showed already. So first one, when you start an echo is your situs view. So your pointer should be at the left side. So it's 3 o'clock. So again, if you imagine the clock around the baby, 3 o'clock is what we found. And then we are trying to visualize this view where you will see the aorta and the IVC. So you will have the aorta on the left side and the IVC on the right side of the baby. So this is the baby, and this is baby's right, and this is baby's left. So I'll just demonstrate now how we capture it.
Right. So we're going to do the subcostal view. So first is the situs
So see,
view.
this is the notch.
This is the notch of the probe.
And then you try to
4 to 12 probe. And for the
so where are we doing? For the situs view, where we will be in the 3 o'clock.
At 3 o'clock.
3 o'clock, right?
As you can see here, it's 3 o'clock. If the baby is like 12 o'clock is here, then 3 o'clock is here, and 6 o'clock is here.
So moment you put the probe, you'll start seeing
3 o'clock.
this. The way you move it, you will start seeing two structures, as you can see here. So you can see the pulsations of the aorta.
Two vessels, aorta, the left side and the right side.
Yeah.
IVC on the right.
You see the pulsations of the aorta, and then IVC was on the right side, aorta is on the left side. So that's the situs solitus. You can put color. Now, many times you don't get a proper sort of color around the vessels.
Solidus.
That's your first view. Okay. So that's your situs solidus. Now you basically rotate. Now see how the probe is getting rotated to the 12 o'clock. The moment you rotate the probe, you start seeing the IVC, and see how I'm fluctuating the probe. I'm seeing the IVC, and as you move, you will see the hepatic, the ductus venosus, the hepatic vein connecting the IVC, and see how the probe is moved. The IVC is also, you can lose the view. So you have to keep a proper placement for the IVC to get visualized. So that's your next view. Okay. Just going further, this is what you will see. So for IVC, it's 12 o'clock. So situs view is 3 o'clock. IVC is 12 o'clock. So this is again Dr. Mohit showed. It's 12 o'clock, and this is what we want to see. A nice sort of vessels coming from the liver, and then the IVC is there. So this is your hepatic vein, and this is your IVC, and the right atrium is what as demonstrated in the picture. Now this view is good for asserting the fluid status. So like in this example, is little bit a congested IVC. So your changes with the respiration are not that much. You will see nice collapsible IVC if this is not congested. So this is slightly dilated IVC, and you can put a Doppler also into it. You can put M mode and see the changes in inspiration and expiration. But IVC collapsibility index and all are not very accurate, especially in the ventilated babies. So we'll not spend much time on that. You can see nice vessels like the UVC entering the liver. You can see they're stopping it somewhere in between ductus venosus or to the hepatic vein, not reaching the IVC. So that can be documented nicely in this view. Or you can sometime look at the clots or something. Or the whole if you go backwards towards the liver, you can actually track the course of the UVC. So it's a good view for tracking the UVC, or sometimes the PICC lines entering and coming up to the IVC, you can demonstrate. And again, anyone can comment, what is this? Any idea what this structure is? It's coming in the towards IVC, but it's in the right atrium. And also, what is this? So people can write in the chat box what they're able to see. The pathology here. I'll play this video as well. So on the left side, if anyone wants to comment, what is this catheter? And on the right side, what is this? Any comments on that? Quickly, people can comment, because we are running short of the time. Anyone wants to put it in the chat box? Am I not able to see? Okay, myxoma, right side subclavian vein, clot, thrombus, UVC. Okay, nice. Valve. Perfect. So I think this is clot. This is an ECMO cannula. Okay, so those who are not working with ECMO, I think they're not probably used to seeing. So this comes from the SVC and goes into the right atrium and towards the IVC. It's a sort of a dual ECMO cannula. It sits in this position. So this is a good view to demonstrate the position of the ECMO cannula. And this is a clot developing at the junction of IVC and the RA. Now coming to the next view. Again, Dr. Mohit has showed this. This is where pointer is at 12 o'clock. Now you want to visualize the aorta, and especially the celiac and SMA and celiac arteries. So this is your liver, aorta is this, celiac artery, and then SMA. And you have to angulate slightly towards the left side for this. And also, if you angulate forward, you will get this aorta is horizontal here. But if you want to Doppler celiac and SMA, this is a good view. But if you want to Doppler the aorta, abdominal aorta, you have to tilt the probe forward so that the aorta comes in this direction, and then you get a Doppler like this. So I'll just demonstrate to you how it is done.
Now
so
again, after IVC, we do the aorta. We're still at 12 o'clock.
12 o'clock.
So facing up. And then now
the moment you put that, see, you'll start seeing this. See, when I move towards right side, you'll get IVC. When I move towards left side, I'll get an aorta. See how I'm shaking and how the picture is changing on the left, on the echo. So tilting towards right will cause IVC. Tilting towards left will get an aorta. and then you put a color box. The moment you put the color box, you'll start seeing the celiac. The first vessel is celiac. The second vessel is SMA. So see how beautifully the vessels are seen. This is aorta, celiac, and SMA. And see my probe. Now I'm tilting it forward. I'm just trying to demonstrate to tilt it forward so that these vessels come in line. So that your angle of inclination is correct. And see here, I tilt it forward, and then these vessels become straight. And I put a color box. I put a pulse width Doppler, and then I get this nice Doppler here. Okay, so that is how you Doppler your celiac and SMA. Okay, so now next one is the PFO. So we have done now IBC aorta. Next one is the PFO. So for the PFO, you have to have 3 o'clock. You have to be in the 3 o'clock. And then you start seeing this 2 chambers of the atria. Here you can see the ventricle shouldn't be seen prominent. So this is your, as Dr. Mohit already showed, LARA. And then the septum in between. And if you see the flap, that's your PFO. Okay. So, and you can freeze it and you can actually measure the PFO or sometime ASD, and you can measure the dimensions in this view. So again, I'll demonstrate how you do.
Now we have to
see the notch is here. 3 o'clock, it's around 3 o'clock, and see how I am deeply pressing. That's very important to demonstrate. I have to go, not only touch, but slightly press so that you will see the both atria. See, once I press, then you start seeing this. If I don't press, you will see like this. You will not be very well visualized. The moment I press, you will start seeing the both atrias nicely. Okay, so see beautifully, you will see both the atria. The ventricle shouldn't be seen properly. You need to focus only on the 2 atria. Now I put the color on. Now this baby doesn't have a good PFO, so you're not able to see the flow across, but you are seeing some SVC flow coming in the right atrium. And what you can do is color compare. So I put a color compare now. It's a 2D on one side and color on the other side, and then see how the flows are. Okay, so this is for the PFO. Now these are some of the examples. So if you have PFO, I see now how nicely this one is flowing. So if you freeze it, you can see nice left to right shunt across the PFO. So this is what you have to demonstrate. And important is that you reduce the scale to around 35-40 to visualize the PFO flow. Because if your scale is high, you will miss this low velocity flow across the PFO. So it's important to reduce the scale also. Now next one is also in this view, again, few more examples. You can see some clots dangling across in the atrium, sometime in the valves. Another clot here. See across the tricuspid valve. So it's a good view for looking at the clots. Again, tip of the UVC, IVC can come in. PIC line tips can come. See, this is the PIC line going into the right atrium. You can see the PIC line tip entering here. You can see the PIC line in the right atrium. So all these things can be confirmed. Now, next thing and the last thing is the bicaval view, which we call. Why bicaval is 2 kV. So this is a view where you put the probe in 12 o'clock. So it's in the center. Your notch is, 6 o'clock. So notch is 6 o'clock. And you're seeing from the bottom up. So this is what the view looks like. And no, actually, this is not the view. This is the modified RVOT view. The bicaval view will be the next one. So the pointer at 6 o'clock. But basically, bicaval is your SVC, RA, and IVC is what is seen. So this is how it looks. Okay, so bicaval view looks like this. So see here on the top, you have SVC, right atrium, IVC. So see here, SVC, right atrium, and IVC. Similarly, what you are seeing in the view here, you have a 2 kV seen and SVC flow also nicely seen. Again, I can demonstrate that how it is captured. So same thing.
Okay, now we'll just show you the bicaval view.
So 12 o'clock.
Here we are
see
at
the notch.
6 o'clock. We are
Sorry, 6
upright,
o'clock. I keep
from
saying
the
12 o'clock.
bottom.
It's 6 o'clock.
The notch is at
Notch
6
at the bottom. You have to press slightly and then tilt towards the right side because you want to see the IVC and SVC.
SVC and the IVC.
So then you will start seeing this view. So see, I'm putting color compare now already. So this is SVC, RA, IVC. You see beautiful red jet of SVC here. And you can do your SVC flow also in this view.
Now we got the SVC.
So again, some adjustment have to make. The moment you move, you lose your view. The moment you adjust, you get a nice, beautiful SVC flow and IVC flow. I hope that's clear, and more demonstration Mohit again can show. And this is again a good view for sometime clots, ECMO cannulas, PICC lines, all those things. Okay, so see, this is a subcostal view. So I think with that, I'll stop. Yeah, SVC flow is also there. So in this view, you can do a SVC flow measurement. If you get a perfectly upright sort of SVC flow, you can put a Doppler, and then you can get a Doppler velocity like this. And then you can calculate the SVC VTI. And for the calculation of the SVC flow, you need to have another modified view. Again, Dr. Mohit can demonstrate that. But that's a different view in the suprasternal region. You try to look at the SVC in this direction, and they put M mode, and that will give you diameter. Because for any cardiac output calculation, you need two things. One is the VTI, which we calculated based on this. And then next is your diameter, which is calculated in this view. Okay, so I'll stop here. I think Dr. Mohit, that's enough. I think I've got this view, just a modified view where you show the crossing of the left ventricle outflow tract. So this is again advanced views. You don't want to focus in the basic views. In the subcostal, you can see this is your LVOT, and then you have the RVOT sort of coming up. Dr. Mohit, I think I'll skip. This is going into the advanced views.
Yeah.
So this is your
better.
Yeah, this is RVOT. So the views, the two vessels crossing each other. If you demonstrate RVOT going in this direction and the LVOT going in the other direction, then that's rules out your TGA. But again, this is an example together. Okay, LVOT going like this, RVOT going this way, crossing each other, and that's your rules out TGA. This is a normal sort of variation. Okay, so I'll stop here. Over to you, Dr. Mohit, for live demo for the remaining groups.
Thank you. So you see, it's situs, IVC, abdominal aorta, interatrial view, interatrial septal view, SVC, atrial view. So these are the subcostal views, which Dr. Kiran has showed you the demonstration of that very nicely. So now what I will do the live demo of a apical 4-chamber, 5-chamber, 6-chamber, low parasternal, that is parasternal long axis, parasternal short axis, and high parasternal views, that is ductal view, pulmonary artery view, and pulmonary vein view. And the difference between the PFO and ESD is one is size, then PFO having the flap, and then the site and this the edges. So there are 3 to 4 differences like this, how we differentiate PFO from ASD. Now I will be going into the unit. So I would request the sport team to spotlight my other device, Voice Honey, which is now, for which the video is being closed for the time being. So you please spotlight that video so that it has been recorded and it remains in the center of the screen of everyone. So hello everyone. So now we will So we will do the basic views, subcostal views. Dr. Kiran has covered very well. So what we will do a apical 4-chamber, 5-chamber, 6-chamber. I will show where to keep the probe and how to do the sweep and what all structures we will see on the echo. Then we will do low parasternal, in which we will do parasternal long axis, parasternal short axis, and then we will do 4 high parasternal views, that is ductal view, your ductal view, your pulmonary artery view, pulmonary vein view, and then subcostal views, which we discussed, has already been shown by Dr. Kiran More just now. So again, same probe, phase array probe. Basically, this probe is typically for echoes, but in head ultrasound we also use that. So the head ultrasound in newborns can be done. The probe has to be cleaned. All that care which Dr. Kamal has told in the morning, it has to be done. But the only thing which we will do is in this is horizontal rack. Here this is on neonatal head mode. So we'll go to the preset and it's past mein kya? I will go. We have 2 folders, term and preterm. This baby is preterm, so I will select the preterm folder. So as soon as I selected the heart, previously I showed you in the live demo, this probe orientation marker was on the right side of the screen for head ultrasound, but now this is in cardiac mode, preterm cardiac mode. So this has automatically come on the right side of the screen. This is sectoral probe. For apical 4 and 5 chamber, I will bring this probe orientation marker down because I want to do a upright. उसको बेटा और पूरा नीचे कर, निवेश पूरा नीचे कर बेटा उसको. इधर आ जा बेटा. So this is the apex. This is where we keep the probe, just below the apex. Pointer is pointing at left shoulder or 2 to 3 o'clock position. This is where we keep the probe at the apex. Pointer is pointing at 2 to 3 o'clock position. इधर आ जा. So now you see the heart. This organ is very small. There is vacant space. So what I will do, I will decrease the depth and make it big so that it covers the at least 60 to 70% of the sector. This is your LA, LV, RA, RV, descending aorta, pulmonary veins, interventricular septum, interatrial septum. So if I sweep the probe up, see from here, pointer pointing at 2 to 4 o'clock. If I sweep the probe up anteriorly, so I will be doing apical 4 chamber and more up is 5 chamber. 4 chamber. If I sweep up, from 4 chamber, this is 5 chamber aorta. Sweep further up, the aorta is gone, and you start seeing this pulmonary artery. Just second. बेटा इसको कवर कर दो ना, पीछे से निकाल. I had to change the baby because that baby is basically operated for NEC the ileostomy, so that area was fully covered with the this thing, bandages. बेटा इसका डेक्सट्रोज डालना 25%, सुक्रोज डालो, सुक्रोज ठीक है। So this is your apical 4 chamber, LA, LV, RA, RV. Very now you clearly seen the sector is 60 to 70%. Your Mindray is good. All the machines are good. Mine is not Mindray, it is different. So this is a apical 4 chamber, LA, LV, RA, RV, interventricular septum, intraatrial septum, mitral valve, tricuspid valve. I sweep the probe anteriorly. This 5th chamber has opened up. Movement. So this 5th chamber opened up. And if you sweep further up, this pulmonary artery, this is 6th chamber, 4th chamber, 5th chamber, and 6th chamber. So these are your apical 4th chamber, 5th chamber, and 6th chamber views. So now next is we will go for parasternal long axis, that is low parasternal, which has been divided into two: parasternal long axis and parasternal short axis. This is your nipple line. This is nipple line. So the probe for parasternal long axis is placed at the nipple line, bit on the sternum or on the left side of the sternum. Probe pointer is pointing towards the right shoulder, that is at 11 o'clock position. Here, the probe orientation marker is to be taken up here, and we get this parasternal long axis. RV, interventricular septum, LV, mitral valve, and this is aorta. If I sweep up towards the head, pulmonary artery will come like this. This is pulmonary artery, the aorta is gone. This is again a plaques view, parasternal long axis view. Sweep probe down, this is your tricuspid. So this is your RV inflow, plaques view, RV outflow, pulmonary artery. Then from parasternal long axis, where the pointer is pointing at 11 o'clock, I rotate the probe at 90 degrees from 11 o'clock. And now I am pointing at 1 o'clock. From 11 o'clock, I am pointing towards 1 o'clock at the same position as the nipple line. So you will see, cut the heart. At the base. So we cut it at the base, what we call as Mercedes-Benz views. So this is your aorta in cross section, Mercedes-Benz view. This is your pulmonary artery, RV, tricuspid valve, RA, LA. From Mercedes-Benz view, if I sweep down towards the apex, the next is, this is your mitral valve, fish mouth view. This is LV, RV, interventricular septum. From there, if I go down, this is your papillary muscle view. These are papillary muscles in your LV. This is the RV. And if I sweep further down, you will notice this RV is gone and this apex is formed by the LV. This is how I sweep the probe. This is at the base. Then sweep towards the apex. From base, sweep towards the apex here. Parasternal long axis, pointer pointing at 11 o'clock. Parasternal short axis, pointer pointing at 1 o'clock. Then from base, you sweep towards the apex. So these are your parasternal, low parasternal views. Now we will discuss high parasternal views. मेरा इसको डेक्सट्रोज डालना, मैं वो लड़की डेक्सट्रोज डाल, मेरे को नहीं तो दे दे, कुछ सिरिंज में दे या कुछ दे, मैं इसको डालूं, मेरे को सिरिंज में दे दे या किस में दे दे, या सुक्रोज दे थोड़ा सा, या वो दे देना डेक्सट्रोज ही. Okay, so for ductal view, what we discussed 4 high parasternal views. 1, ductal view. 2 pulmonary artery view, 3 pulmonary vein view. Pulmonary artery view, pulmonary vein view, and ductal view. These three are done from the left subclavicular area. That is on the left side of the sternum. And arch view, see in this baby, you can see the neck is very small. Suprasternal notch is very small. So it is very difficult to do. So we do the arch view from the right subclavicular area. And all the other three views, pulmonary artery, pulmonary vein, and ductal view, we will do on the left side of the sternum. So first we will do ductal view, where the pointer is pointing at 12 to 1 o'clock position on the left side of the sternum, just below the clavicle. This is clavicle, just below the clavicle. Just below the clavicle, pointer is pointing at 12 to 1 o'clock position. Idhar aa ja. So in ductal view, what we need to have, we will have 2 ml में भरना था, 1 ml में काम नहीं आएगा. छोड़. और भर के ला. So what we need is, we need to have pulmonary artery and descending aorta. So this is your ductal view. If I put a color, you will see two blues. And in 2D, this is pulmonary artery, aorta, pulmonary artery and aorta, two color. Even though this baby is less than 1 kg on CPAP, but there is no duct here. Okay, so this is ductal view. Pulmonary artery, descending aorta, pulmonary artery, descending aorta, both blue color. There is no red connection, so there is no duct. So this is your ductal view. Now, in the same position, for the ductal view, where my pointer was pointing at 12 to 1 o'clock position, I rotate the probe to 3 o'clock position. In the same window, same position, I rotate from 12 to 1 o'clock to 3 o'clock. So I will get pulmonary artery view. दे बेटा दे मेरे को. उसके वो चेस्ट लीड्स दिखा देना, मैंने चेस्ट लीड्स निकाले थे. Left subclavicular area, pulmonary artery, MPA, RPA, LPA, and this is aorta, and then below here is SVC. This is your pulmonary artery view. So I keep the probe there and sweep bit downwards. As soon as I sweep downwards, LA opens up. In LA, you have 4 pulmonary veins. I can put a color. The scale is more. So what I will do, I will bring down the scale to 0.35. You can see the scale has been decreased to 0.35. And you can very well see these 2 red jets. These are right lower, left lower pulmonary vein, and the upper are blue. The blue is basically the upper veins which are moving away from the probe. 1 and 2, right upper, left upper, 2 reds. So all the 4 veins you are seeing in this is known as crab view. Very nicely you can see 4 veins in this. Color and black and white, 2D both. So this is your crab view. So pulmonary vein view, pulmonary artery view, and ductal view. So these are the 3 left subclavicular or 3 high parasternal views. Now we will go to right subclavicular area for the arch view. This pointer, the probe, instead of left subclavicular area has been now shifted to right subclavicular, to the right side of the sternum. The pointer is pointing at 12 to 1 o'clock position. And you will see the arch. This is your ascending aorta, arch, 3 branches. Very nicely you can see 3 branches. 1, 2, and 3. This is your RPA and descending aorta. If I put a color, baby is crying, that's why there is disturbance. Otherwise in 2D, very nicely you can see. That's why we do the subcostal views in the end, because especially the babies on CPAPs and all, these babies on CPAP, they are very irritable. So this is your arch view. Very nicely, you can see the arch. So put a color. I have to now bring up the scale 0.7. So this is ascending. That's why it is red towards the probe. Rest of the arch is blue. 3 branches. The whole arch is there. So this is your arch view, which I have taken from the right subclavicular area, not from the suprasternal notch, because the baby's neck is small, baby is 1 kg. So this probe foot will not fit into suprasternal area. So what we have done is, we have done apical 4-chamber, 5-chamber, 6-chamber view at the apical window. Then I did parasternal long axis view, probe at nipple line, pointer pointing at right shoulder 11 o'clock. We did 2 sweeps. Sweep down is tricuspid valve sweep. Sweep up is pulmonary artery sweep. Then I rotated the probe from 11 o'clock to 1 o'clock at the same nipple line at the baby's chest, sternum. I cut the heart in cross section in short axis from the base where we see the Mercedes-Benz sign view, then swept the probe towards the apex. The next was mitral valve or fish mouth view. After that, there was a papillary muscle view, and then the apex forming chamber view, and that was the parasternal long axis and short axis. Those are low parasternal views. Then we went to high parasternal views. In high parasternal views, we first discussed 3 left subclavicular, that is on the left side of the sternum in the upper 1/3 part of the chest, ductal view, where the pointer was just below the left clavicle and the pointer was pointing at 12 to 1 o'clock position. We saw a ductal view, and then the pointer was at 3 o'clock in the left subclavicular area. There was a pulmonary artery view, sweep down, that is posterior sweep. We saw pulmonary vein view, that is what we call as crab view. And then we brought the probe on the right side of the sternum, right subclavicular area, pointer pointing at 12 to 1 o'clock position. We saw just now, we saw the arch view, ascending aorta, transverse aorta, and descending aorta with 3 branches. So that is your arch view. And after that, we go for subcostal views, and that subcostal views have already been discussed by you, by Dr. Kiran. I will just see if there is any chat. If you have any issues, you want me to show you something, write in the chat. Yes, that is particularly we do, but for demonstration, that's why I kept a full color so that I can show you the whole sector comparable in 2D and color. But he is very right, Dr. Abdul is very right that it color window has to be small because it affects your sharpness, your pulse repetitive rate and everything. So those are the finer adjustment we need to do. But I intentionally did that to show you the comparative color and 2D. Different machine have different buttons to increase and decrease the scale, so that you have to get accustomed to your machine by how you can. Every machine has got a different button to increase and scale the gain. Right subclavicular. Okay, I will show you the situs view. This is right subclavicular area. Just this is the area, sternum. This is the right side and this is left side. Left side of the sternum, left subclavicular area. Right side of the sternum, right subclavicular area. So this is your just below the Xiphi sternum. बेटा मेरे को वो देना ना, हाँ ये इसमें थोड़ा भर देना. I will show you the situs. For situs, we put the probe in the subcostal area in the Xiphi, below the Xiphi sternum. Pointer is pointing at 3 o'clock position. Pointer is pointing at 3 o'clock position. Here. First, you need to identify liver. So liver is 3 o'clock. So this is left side, this is right side. Liver is on the right side, and this gastric shadow is on the left side. So that means liver is right, stomach is on the left. So that is one thing is maintained. Liver is on the right, stomach is on the left. Then we see you can see this circular tortuous vessel, and then you have this circular vessel which is within the liver. Okay. Then we press the probe. When I press the probe, this gets compressed, this does not get compressed. So that means this is abdominal aorta, and the one which is in the liver getting compressed is IVC. So that's how we determine the one situs is maintained, liver is on the right, stomach shadow is on the left. Then isko charging mein laga bhai idhar. And then we see when we press the probe, the vessel which is tortuous towards the gastric shadow does not get compressed is your abdominal aorta, and the one which gets compressed is within the liver is your IVC. So that's how we diagnose the situs. One is maintained. Second, on the right side there is IVC, on the left side it is aorta. हो गया start. वो चढ़ा के लगा देता हूँ. So see, in my machine, you can change it by these buttons. You can move it up and down. And then there is a machine button here. You can move it right or left. So in all the machines, you can move it up, down, right, left. In cardiology, it should always be on the left side. In radiology, it should always be on the right side. Okay, now I'm going to the this thing to my laptop, and then we will start with the lung ultrasound session. Please कर दे इसको. So hello everyone, I hope that was helpful regarding the views of the, yes, a lot of practice is needed. So to keep on practice, keep on seeing the videos, keep on getting the sessions, so then it will be helpful for you. Great. So now our next session will be of lung ultrasound. So that will be done by Dr. Surjit. You see. So again, for practicing or anything you need, you can reach us by NfECHO 2505 @gmail.com or on the WhatsApp number The WhatsApp number is 777-89-89842. 777-89-89842. You can follow and subscribe to NfECHO YouTube channel, or you can message us on nfecho2505@gmail.com. Let me call Dr. Sujit. She's supposed to be here. Just a second, there is some technical glitch from her side. I'm just resending her login. She will be joining soon. So till that point, I will just take on few questions. If you have any issue or anything, please write in the chat box. The recording videos will surely, we will share the link in the group with everyone. If anything else, okay, Dr. Sajid has joined. Yeah, PPHN and all, yes. See, again, I told we cannot complete those pathologies in single this thing. Otherwise, it would take at least 2 days. Okay, so surely we will do the sessions separately, 1 or 2 hour CMEs on PPH and shock and all. So, Dr. Sujit, are you there?
Yes, sir.
Okay, so we welcome Dr. Sujit Madan. She is from Jalandhar and she has done her fellowship in neonatology, and she has been running her NICU and pediatric hospital. She has been doing a great work in neonatal hemodynamics, and she has done one multi-center trial with us, along with us. And her special interest is on lung ultrasound. And our 6 months course do include lung ultrasound. At least 6 to 8 sessions are there, almost 3 weeks sessions on lung ultrasound. So we will, again, I am telling that today we will cover only our basic views, basic things what we see in lung ultrasound. And this is what she will be covering. There will be a lot of pathologies which we will discourage to discuss, as we have done in our previous sessions, like in echo and head ultrasound. We are trying to cover only the normal variants and normal views. So welcome, Dr. Sujit. Please, over to you.
Yeah. Good evening, sir. Am I visible? And
Yeah, we can see you, and we can see your slides, and we can hear
okay,
you.
okay. Good evening, everyone. I hope you all are awake after such a long and so many sessions. And we'll start.
People they have gone to sleep. They were around 419, and there
Okay.
now there are 219.
Okay.
So 200 people they have gone to sleep.
Anyways, it's a Sunday evening, so they have excuse. Okay, let's start with the basics of lung ultrasound. Yeah, previously it was known that we can't do a lung ultrasound. It was known that ultrasound is done only for the soft tissues or wherever there is the fluid, because air is a bad conductor of ultrasound waves and it reflects all the waves like a mirror. So, and same with the bone. Bone was known to be enemy of lung ultrasound, and bone absorbs the sound but doesn't pass. So the fluid is a lover of ultrasound. Fluid lets ultrasound waves pass easily, and same is with the soft tissues. Soft tissues are very friendly to the ultrasound waves, and more the soft tissue, more easy is for the waves to pass and get the images. So when we do a ultrasound of a liver or maybe of a kidney, you actually see the lobes of the liver, you see the cortex, medulla, you see the size of the kidney. You can actually see how it is anatomically formed. But in lung ultrasound, we cannot see the lobes of the lung as it is formed. We actually see few artifacts. And then these artifacts are formed due to reverberation of the pleural line when these ultrasound waves pass and they encounter the alveolar gas liquid interface. Few artifacts in different forms, maybe vertical or horizontal lines or dots, are seen. And these artifacts are interpreted, and then we analyze the physiology or the pathological conditions of the lungs. So if there is any physiological changes in the lungs, the parenchyma will change, the artifacts what we are seeing in the scan changes. So then we analyze these artifacts and then we relate these artifacts to the pathological conditions of the lung. This is how the lung ultrasound is seen. So previously, what was known that for lung we only do chest X-rays or maybe the CT scans was done. Why? Because we thought nothing else is available and nothing better is there other than these two diagnostic tests. But when we want to do X-ray or CT scan, it is a time-consuming process. We need the transportation of the baby, and the sensitivity and specificity is low, and the baby or the patient gets exposed to the radiations. So when do we do lung ultrasound? We do whenever in a neonate, if a neonate has respiratory distress, or maybe there is sudden deterioration of respiratory status, or a baby comes with cyanosis, or there's grunting, or there is retractions, or baby is going into apnea. Or maybe sometimes we have seen that in antenatal scans, there are some lung abnormalities. And we want to see the response to the treatment. Once you might have started some antibiotics and you want to see how the baby is responding to your antibiotics, or maybe you want to give surfactant in RDS cases, you want to score the ultrasound of the lung, and then you want to give surfactant, or maybe you have given one dose of surfactant and you want to repeat another dose. So rather than giving radiations to the babies, you can do a lung ultrasound, you can do your scoring, you can analyze, then you can decide if you want to give another dose of surfactant. So this lung ultrasound guides you whether you need to give surfactant and whether you need to repeat the surfactants, and you can monitor your respiratory cases, you can monitor the illness, you can monitor the response of your medications to the patient. So the advantages are that it is a dynamic technique and it allows the analysis of the lung in the real time. You can do it very fast. Once you have learned lung ultrasound, it hardly, I think, takes 1 to 2 minutes to do your lung ultrasound. And it is a bedside test. There are no radiation exposure, and multiple examination or multiple scans can be done without any radiation to the baby. And the sensitivity and specificity is very high, and it helps in thoracocentosis and the fluid management. In case a baby has lung edema, you want to adjust your fluids, or in the lung recruitment assessments, or you want to perform any procedures. And it is you who is doing it, and you who will be deciding and seeing the You'll be giving the report. So it is a clinician who is performing and interpreting, and clinician is managing the case. So if we ourselves are doing the scans, definitely we can correlate with the clinical condition of the baby, and then the decision making would be much better. But the limitation is that it is operator dependent. It is you who have to learn the ultrasound. If you need to do yourself, then only then the scan can be done. So how do we do? We use a probe, a linear probe with the high frequency that is more than 9 megahertz. This is a linear probe. Usually what sir must have shown in the echos, you are using the sector probes or the curvilinear ones. So the hockey sticks are also available, which are very good for the preterm and ELBW babies. And these hockey sticks have better resolution, very high frequency. The resolution is very good. So for the preterm babies, this is really helpful. And the position of the baby has to be supine. If you're doing in the supine position, then you will have to do in side position and also in the prone position. And the baby has to be in a quiet state. There are two techniques how we can do a lung ultrasound. There are 6-region techniques and 12-region techniques. 6-region means this cell, you can see this image. This is anterior area on the left side. This is a lateral area, that is the axillary area on the left side. And this is, the posterior area on the left side. Similarly, 3 regions on the right side. So you have to scan separately all the 6 regions, 3 on the left side and 3 on the right side. So this is 3-area technique, that is 3-region technique. There is another technique which is where you have to cover 12 areas. So 12 areas, again it is anterior, lateral and posterior, but again that is divided into an upper and a lower area. So left side, upper and lower, left side, lateral, upper and lower, and posterior, upper and lower. So on the left side, you have 6 regions, and similarly, the similar 6 regions on the right side. Right anterior, upper, lower, right lateral, upper, lower, right posterior, superior and inferior area. So this is 12-area technique, and whichever technique you are following, let it be 6 areas or 12 areas, you have to do in all the areas. Not that you do on the left side or you do in 3 areas and just leave it. You have to do separate. You have to keep your probes in separate 12 areas, and then you will have to analyze. We use a 2D or grayscale for lung ultrasound. MODS is done sometimes for seeing the moving interfaces. The position of the probe has to be perpendicular to the chest. You will not tilt it. There has to be no tilting to the left or right. And the probe marker is always upwards towards the cranial side. So this is the linear probe. This is the probe marker, which is towards the cranial side. And look, this is perpendicular to the chest wall. If you tilt it to the left or right, you will get false artifacts. So if you want to see the proper things, you have to keep it perpendicular. This is an anatomical picture. This is the skin. This is subcutaneous tissue. These are the ribs. These are the intercostal muscles, and this is a pleural line, and this is a parenchyma. So this is an anatomical picture which I showed. So this is skin soft tissue. This is how you see in the scan. This is a pectoralis muscle over here in the scan in 2D picture. These are the ribs. You can see as a black picture over here. And in between the 2 ribs, you can see intercostal muscles. And this is a intercostal space. And this black thing is a space between the 2 intercostal space. This is a black area. This is how it is seen. This is a skin soft tissue. These are the ribs. and this is a pleural line. This is a parenchyma, and this area between, this is the black area, and this is called shadow cone or the acoustic cone, acoustic shadow. So this is a pleural line. Pleural line is seen in a normal, pleural line is seen in, this is a thin, smooth, whitish, that is hyperechogenic line. Just 1 second. Just 1 second.
Hello. Hello, Dr. Sujit.
Yes, sir.
Yeah. So, so those were the basic. You want to show something?
Yes, yes, sir.
Yes.
Yeah, we were here at the pleural line. Pleural line is a hyperechogenic line. This is some issue. Okay. But this will not be full screen then. It's okay. I'll do it like this.
Why this is happening? What is happening?
Is this okay? And this,
But it looks small.
yeah.
उसमें नहीं जा रहा है क्या?
वो स्लाइड अपने आप स्लाइड हो रहा है.
वो इसलिए हो रहा है क्योंकि कि आपका इसमें शायद प्रोग्राम वो होगा इसमें ऑटोमेशन. Somebody must have did the timer on. So somebody must have done the timer on. So don't worry, just keep on. Yeah.
Okay. Fast.
You will do.
Yeah.
Now if you do, yeah.
Okay,
Yeah,
so
it's-
this is
it's-
a pleural line, which is a thick hyperechogenic line, and this is a shiny line, which is less than 0.5 mm thick. This is not sliding now.
Double click करना. Click करना.
I'm doing it.
What has happened?
Yeah, so the lung sliding is actually seen when there is a pleural line. You need to see the sliding of this pleural line. That is called lung sliding. So it is actually formed due to the sliding of the visceral and the parietal pleura against each other. And this pleural sliding has to be there in a normal lung. So here we can see this is a pleural line and see it is moving. So this is a normal lung sliding. This is how it looks. So if the lung sliding is absent, it means there can be a pneumothorax, there can be a pleural effusion or severe pneumonia, ARDS, or pneumonectomy. So now we'll go to A lines. A lines in lung ultrasound means A stands for air. So A lines are formed due to the reverberation artifacts caused by the pleural line. They are echogenic, horizontal, parallel to the straight solid pleural line. They are equidistant from each other. A lines indicates air, whether physiological or pathological. So I'll show you the A lines. These are the A lines. This is a pleural line, which is a thick, shiny, and these equidistant horizontal lines, these are A lines, which are seen in the normal lung. This is a pleural line, and these are the A lines. These all are the A lines. So now we come to the B lines. B lines, B stands for B lines in lung ultrasound. And these lines represent, they are vertical laser-like hyperechoic artifacts extending from the pleura down all the way. It moves with the pleura. These are produced because of the reverberation artifacts within the fluid bubbles that occupy the intralobular and interlobular spaces and intralobular spaces. So I'll show you how the B lines look. See, these are the B lines. This is a pleural line, and these vertical hyperechogenic lines, which starts from the pleural line and goes till the base. These are the B lines. These are even normal seen in 24 to in the initial 24 to 48 hours after birth. And more of B lines indicates that there is pulmonary edema or maybe congestive heart failure, pneumonias, respiratory distress syndrome, TTNB, and lung contusions, and maybe in the initial 24 to 48 hours of life. This is how they look. Starts from the pleural line and goes till the base. So when there are B lines which occupies the whole of one intercostal space, then they are called as confluent B lines. And if these confluent B lines are seen in more than 3 areas in this view, in the whole sector, in the whole window, then they are called as alveolar interstitial syndrome. If they are seen in more than 3 intercostal spaces. These are the severity of B lines. This is how alveolar interstitial syndrome looks like. So now we go to the compact B lines. Compact B lines refer to the more concentrated B lines, and that causes the acoustic shadows which are present, which are formed due to the ribs, and that black shadow which I showed you initially, that disappears. If there are more B lines, such B lines are called as compact B lines. This ones. Here we are not, you can see here we are not able to see the acoustic shadow. It has been obliterated by the B lines. So this we call it as compact B lines. So these are the B lines and this is AIS. Now we come to the C lines. C stands for comet tails in lung ultrasound. These are short path reverberation artifacts that weakens with each reverberation. These are also vertical echogenic artifacts like the B lines, but they fade away. Till they reach the base of the screen, they fade away. And they resemble like a comet tail. See, these are the few vertical lines which are starting. You can see here, but you're not able to see them till the base. So this is how we differentiate comet tails from the B lines. So there's a seashore sign or sandy beach sign. This is a normal sign seen in a normal lung. So when you you go into 2D echo and you need to put a M mode on that. And you put a M mode, then I'll show you the picture. This is how you see. This is a skin, soft tissue, and this dark line, hyperechogenic line, which is in between the upper and the lower area. The upper area, which is a motionless, that is the skin and the subcutaneous tissue, is seen as the horizontal lines. And then we see the pleural line, and below that you can see the dotted areas, which looks like a sand. So this is a sandy beach. This is sand, and this is a beach. So this is a sandy beach sign, which is seen in the M mode in a normal lung. Do we have to cover RDS and other pathologies also, sir? I'll just show you in short the ultrasound findings of RDS. We see the air bronchograms. We see the pleural line abnormalities in RDS. And in RDS, the A lines disappear. And there might be a whiteout lungs. There may be subpleural consolidation. These are the different, you see in the different grades and different severities of RDS. And the pleural line is usually thickened. It is more than 0.5. And there is obliteration or irregularity of the pleural lines, and you can even see the subpleural consolidation. And this is in RDS, it is seen to have 100% sensitivity and 45% specificity. And in RDS, the A lines usually are obliterated, or there are lack of A lines. And you do the scoring. I'll tell you in short how to score. We see the 6 regions as I had told, and then you see the B lines, you see the severity of B lines, and then you grade. This is how, if you are seeing A lines and there are no B lines, we grade it at 0. And if there are more than 3 B lines, then you grade it as 1. And if there is AIS like a pattern, which I had told you, more of a compact kind, or the AIS like pattern or compact B lines, you grade it as 2. And if there is subpleural consolidation, just below the pleural line, you can see these bronchograms, that is subpleural consolidation, then you grade it as 3. So you do this in 6 regions. So maximum score would be 3. So 3 into 6, 18. So maximum score would be 18. And then you see like what is the scoring, and accordingly you decide whether you want to give surfactant. Yes, definitely you will correlate your findings with your ultrasound findings with your lung clinical condition of the baby. This is how you grade it as 0, 1, 2, 3. You score the lung ultrasound findings. And I'll just show you a few pictures. This is consolidation. Just below the pleural line, you see these dotted bronchograms. And this is called shred sign. This is seen in consolidated lungs. In TTNB, you see a double lung point. This is the upper area, which is non-aerated, and the lower area, upper area, which is aerated, and the lower area, which is non-aerated. This is the A lines, A profile picture. In the lower area, you get a B line. So this point in between is called as double lung point. So this is aerated, and this is a pulmonary and interstitial edema. As we know, this is seen in the TTNB. So these are a few cases. This is RDS, how you see the whiteout lungs with the subpleural consolidation. This is irregularity of the pleural lines, and this is subpleural consolidation. So when I want to score this area, I would
Sujit,
3. Yes.
2 minutes more.
Yeah, so like we have almost covered with the basics. These are few pathological conditions. And when we gave surfactant, then this is how I'm able to see the A lines. So this is how you can actually see the response to your surfactant. So this is a case where a baby presented on day 6 and you could see this is pneumonia, consolidated lungs. We'll just go through the pneumothorax. When you put a M mode, there are certain other, see, when there is a pneumothorax, the A lines are seen and the B lines are absent. The lung sliding is absent. These are the few findings which you see in lung ultrasound in pneumothorax, and you can also find a lung point. So when you put a M mode, this is a normal lung, which I had told you. This is a sea and shore sign. But in a pneumothorax, this is how you see. This is called barcode sign. I think we are like almost done. This was a case with a pneumothorax. This is how we could see the stratospheric sign or the barcode sign in pneumothorax. This is a normal lung on M mode, sandy beach sign. Just a comparison between both. So the take-home message is that no artifact will give you the exact diagnosis and the pathology of disease which is going on in the lung. It is very important that the current complaints, the clinical condition of the baby, the medical history, the physical examination, and the history during the delivery, and these all need to be known by the clinician. And then you will do a lung ultrasound, and then you will have to correlate with the clinical findings and the ultrasound findings, and then you will have to make a decision what has to be done. One should always ask whether the severity of the patient's condition is getting correlated with our ultrasound findings. Only then a bedside decision must be made after your lung ultrasound. Thank you, sir.
Great. Thanks a lot. So I know it's very to finish off the things within 30 minutes, especially the lung ultrasound. But today we will be just concentrating more on how to look for the normal signs, normal artifacts in the lung. That is what Dr. Sujit explained regarding your pleural line, lung sliding, A lines and B lines. If we are able to recognize this much, so that is what Dr. Sujit, what she has explained. So that is something that we have achieved. And I'm still, really, it's really appreciable that after 5 hours of marathon presentations and session, still more than 200 people are there online. So it's really appreciable for everyone. So thanks for being there. So now in the end, what Dr. Sujit has just explained in the session, I will just show you on the baby. I will show mainly, I will consider lung sliding, pleural line, A lines and B lines, this much. The rest of the things for TT and RDS scoring and this thing, we will leave it for the advance or basically for our 6 months course. And I will show you that probe. What we use is, as she has told us, linear array or hockey stick probe we will be using. And the regions I will show you, 6 region approach most commonly is being followed by all of us. And then on the baby, I have already shown you the echo. So this baby is preterm on CPAP having RDS, but I will not discuss RDS because that is not an objective. And please stay till the end, because in the end there is one very interesting announcement will be there, and that we will be doing in next few days. So that interesting announcement will be there. So be there for that, and I will just finish off what Dr. Sujit has shown you as in the session. I will show you in the live demo on the baby. So for the sport team, please spotlight my other device, my phone, please. Thank you.
Thank you, sir.
So hello everyone. So this is the probe. This is a hockey stick probe, or you can use, so this is a linear array probe, but in newborns we call it hockey stick, is high frequency probe, and the free end is the probe marker here. So this is a linear array probe that we use in newborns is known as hockey stick probe. So this probe normally we use for the lung ultrasound, for seeing the vessels, for putting in the central lines, ultrasound guided central lines, like internal jugular and femoral in the newborn, and then locating superficial, doing the Dopplers of the superficial vessels and all. And then as soon as we attach this probe, so automatically this lung ultrasound things comes in, and this is how it will come. But in the preset, vascular superficial this thing I take because it becomes more wide. Here I told you in radiology, this is the probe marker, probe orientation marker. It comes to the left side of the screen, and it will match to the free end of the probe. So this is probe marker, automatically is seen as the free end is the probe marker, and this is probe orientation marker. Here, the regions of the lung. How we divide is basically from this central part of the sternum till the anterior axillary line, anterior region, anterior axillary line to posterior axillary line is lateral region. From posterior axillary line till scapular line is the posterior region. So this is left anterior, lateral, and posterior. 3 regions on the left. Similarly, 3 regions on the right. Right anterior, right lateral, right posterior. 3 on the right, 3 on the left. Total 6 region approach. In 12 region, what we do is we may again draw a line, nipple line. So what it does, it divides the regions horizontally. So now anterior region is divided in right, anterior region is left and right. So left upper anterior, left lower anterior, left upper lateral, left lower lateral, and then left upper posterior and left lower posterior. This is how it gets divided. But now you see, if I put a probe here, most of the area will be covered by the probe. So that's why we use 6 region approach. So this is linear probe. This probe marker is always being kept towards the cephalic side, towards the head, up. And the probe foot is perpendicular to the direction of the ribs. The rib direction, it is perpendicular to that. Okay, now I will show you. If I keep the probe on the left anterior. This is what you are seeing. Skin, subcostal tissue, ribs. Now you see this white thickened line. So this is your pleural line, and as you can see, it is moving in the respiration. So this is your lung sliding, and the horizontal white lines you are seeing is your A lines. And here, in between, you are seeing this vertical hyperechoic lines that are not going till down the whole sector. So they are a comet tail artifact. Comet tail. Comet tail means less amount of fluid. So lung sliding, ribs, subcostal tissue, intercostal muscles, and then in the lung tissues you are seeing the horizontal white lines. So they are basically nothing but your A lines. And incomplete vertical hyperechoic shadows not going till down are your comet tail effect. So if I want to score it for RDS, it is 0 because I am able to see A lines. Now I am going to the posterior lobe. So if I do M mode of this normal lung sliding with A lines, so this is what I will get as M mode. So this is your sandy beach sign. This is pleura, this is your water, subcutaneous tissue, and this is lung. So this is how your sandy beach sign looks like. So this is your sandy beach sign. So that is normal lung ultrasound M mode. So what we have seen skin, subcostal tissue, intercostal muscles, ribs. Below that, hyperechoic white line, what we call the pleural line, which was moving, so lung sliding. When we did M mode, so there was a sandy beach sign, I could see. And the vertically, we could see hyperechoic shadow that does not go to till the base. So that was basically nothing but your comet tail artifact. So even we were not able to see the B lines in this baby. Let me do the ultrasound on the right side and see if I could have any B lines somewhere. So a lot of comet tails are there. Now in this, can you see this here? There is hyperechoic lines which are moving with the pleura, vertical lines. And if you are not able to see A lines through that, so that is your B lines. So in this sector, there are 1 or 2 B lines are there on the right side. Hyperechoic. Here, if you concentrate here, yeah, this one. This is your B line because it's starting from pleura, going till the end of the sector. And now I'm not able to see any A lines through this. Here I am able to see A lines, but no A lines through this. So this is your B line. So what we saw, A lines, comet tail, and B lines. Lung sliding, pleural line, and sandy beach sign or seashore sign. So this is what are the normal features of the normal lung in the newborn. Huh? B lines basically because of the fluid and air interface. So that shows so in the preterms and the normal newborns, B lines can be normal. Then it all depends on the number of B lines. So then we have confluent B lines, AIFs, compact B lines. C lines are basically the comet tail. Comet tails are little amount of fluid. So it is less clear than the B lines. See, 12 is more precise, but practically what we follow is 6 region approach. As soon as you will attach the linear probe, it will automatically will give you this settings, what I am showing you in Sonosite. So the linear array probe, mostly they are of 12 to 15 hertz. This probe which I am showing is a hockey probe is 12 to 20 hertz. But normally all linear probes or hockey probes in other machines are 12 to 15 hertz. Okay, I will again show the B lines. See the vertically, you are seeing these are comet tails. This one, concentrate here. Here, 1 or 2 B lines are there. They move with the pleura vertically, horizontal. Vertical lines, horizontal are A lines, vertical are B lines. Here, this is the B line. So I will log out through this phone and I'm going to the laptop and then we will just finish off in 5 minutes. So please bear with us and we will do one good interesting announcement also. Thanks a lot, everyone, for being there. Dr. Sujit, you are there. Okay. So,
Yes, sir, I'm here.
thank you very much for the sessions and for your session lectures. And so I think so it was helpful for the people. Again, those who are interested can email us or WhatsApp us for the courses. WhatsApp number is 777898942, NfECHO2505@gmail.com. Please follow and subscribe to the NfECHO Neonatal Echo channel and follow the Facebook and Instagram pages. So that more extensive, more time utilization if you do, it will be helpful for you to make a clinical decisions and immediately diagnose the things. And there was some announcements I will be putting in the group. So on neonatal hemodynamics, we will have a session like online, multiple choice, fastest finger first kind of one kind of funny competition. And for that, we will be doing that competition, and the first 3 prize winners, we will give them the books. First prize winner will get 2 set of books. Second will get a big book, and the third one will get a small book. I will be putting the details and everything in the group. So those who are in the group, plus keep on follow that. I will give all the instructions, put all the instructions in that. So now Dr. Kiran is there with us, Dr. Sujit is there. So we will have the final words from them, and then we will stop this session. So Dr. Kiran, it was good. Like after 5 hours of marathon, this thing, still for the last lecture, there were more than 200 plus people were there.
Yes, yes. I think I can see the enthusiasm. Seriously, I mean, really surprised with the kind of enthusiasm. Like even the response we had at the beginning. So many people are interested to learn echoes and point of care ultrasound. And from beginning, I think around 400, more than 400 participants were there, and 200, as you said, till the end. And lots of good questions. Again, so people are definitely doing, and very appropriate questions people are asking. So I can see a lot of enthusiasm is there. And although it's a very short time to cover such a big, vast topic, even 4-5 hours is not enough. Sometimes 1 or 2 days workshop is not enough. So I think we tried our best. And hats off to you, Mohit. I think you've been like last 5 years, you're constantly there. I was in and out a little bit, but great effort from everyone. And I think it was really encouraging for us to see the enthusiasm. So we'll do more sessions online, as you mentioned, some specific disease-specific PDA, PPHN sessions. And yes, I mean, those who are interested to learn it formally, definitely, as Dr. Mohit has mentioned, the courses are there, because you need to dedicate yourself at least those 6 months and focus on learning, reading, practicing, because it's not the skill you learn in a day. It has to be practiced over a few months. You need at least 50 to 100 scans before you actually get to a level where we can confidently scan. Because some basic scanning is easy when you begin, but to do it consistently and rule out structural heart disease and all those things, I think it takes time. So you need to dedicate. And obviously, to solve. So more than welcome to join. Yeah. So yeah, I think good session, Dr. Mohit, Dr. Sujit, and Kamal, everyone. So thank you again for organizing and making me part of this. So over to you, Dr. Mohit.
So you are a part of you are a parent.
I know.
One is mother, one is father. Now it is on you. You want to be
Yes,
father
yes.
or mother.
Yeah, it doesn't
And
matter.
then rest are the arms and eyes of the whole
Yes,
group.
correct.
So
Correct.
now it depends upon Dr. Sujit. She wants to be eye or arm. Okay,
Both are
great.
important. Both are very important.
So we'll keep on updating. We will be posting the link for a recorded link in the group, and the rest of the information we will keep in the group, and we will have that small competitive session like multiple choice question session, that we will just do things that what all we have talked about for 5 hours. So was it useful for you people or not? Thank you very much. And I would again like to thank Sipla and all our supportive staff who is there, who has made this 5 hours tirelessly. They have been there, support us, and flawlessly they have conducted, run this whole show. So thank you very much. Thanks a lot to all the faculty.
Thank you to the delegates also. Yeah, patiently.
Yes, well, the big thank is for them, sport team, Sipla, and the best part of this, the whole thing is you all remained there, you all joined, and you be there and made it interactive. So that is the most important and the best part of the whole CME.
Big
Thank you very
thanks to
much.
Dr. Mohit sir for conducting this workshop, and I'm sure it was beneficial and everyone must have learned a lot. And I appreciate your enthusiasm for continuously teaching for last 5 to 6 hours, that too on a Sunday afternoon. Really appreciable. Sir.
Thank you. Bye. Bye everyone. Thank you.
Bye. Bye, everyone.
Bye.
Great. Thank you very much.